little housekeeping. For your reference, financial disclosures of the speakers are available below in the description area of the live stream page. If at any time during this activity you feel that there has been commercial or promotional bias, bring it to our immediate attention. And please answer the questions about balance and objectivity in the activity evaluation. Also, you will have a link for Poll Everywhere that has been sent to you. We really welcome your questions, and we encourage you to post your questions during the presentations, and we do have time after each presentation to try to answer them. Please take some time to visit our virtual exhibit hall during the break. A link to the virtual exhibit hall is located below in the description area. Okay, so with that, I wanted to go over our agenda today. Our first speaker is Dr. Sheetal Shroff. Dr. Shroff is an assistant professor of neurology at the Department of Neurology, Stanley Appel, here at Houston Methodist. She actually was educated in India, did residency in UT Galveston, and we had the pleasure of training her as a fellow several years ago in neuromuscular medicine. She will be giving you an overview of myasthenia gravis, and now I'd like to welcome Dr. Shroff.
Thank you, Dr. Green. Okay. I'm Dr. Sheetal Shroff. I'm one of the neuromuscular specialists here at Houston Methodist Hospital. And my topic for today is overview of myasthenia gravis. And these are my disclosures. Okay. So I'll be going over historical perspective of myasthenia gravis, epidemiology, pathophysiology, clinical features, and diagnostic studies of myasthenia gravis. The first case of myasthenia gravis was described by historical chronicles from Virginia on Chief Opequacanough. I hope I pronounced it right. There the description goes like this. The excessive fatigue he encountered wrecked his constitution, his flesh became macerated, the sinews lost their tone and elasticity, his eyelids were so heavy that he could not see unless they were lifted up by his attendants. He was unable to walk, but his spirit rising above the ruins of his body, directed from the litter on which he was carried by his Indians. So this was one of the earliest descriptions in the literature which is there. Now next in 1672, Thomas Willis in his book called De Anime Brutorum, meaning function of brain, he describes that there is a substance called explosive copula in the blood, and fluctuation of the level of this substance in the blood probably caused varying paresis, such as observed in some of his patients, and he called it as spurious palsy. In 1877, Sir Samuel Wilkes, he described it as bulbar paralysis, fatal, but no disease found. So this was a case of bulbar paralysis whose weakness fluctuated throughout the course, but resulted in death. Autopsy was done, brainstem looked completely normal to naked eye and to microscopic examination, and there was no change in the tissue. So no disease or cause of death was not found. In 1879, Wilhelm Erb described 3 cases of myasthenia gravis, And this was the first paper dealing entirely with this disease. He drew attention to some of the clinical features like bilateral ptosis, diplopia, dysphagia, facial weakness, and weakness of neck muscles. He also mentioned remission and relapses in his paper as well. In 1895, Frederick Jolly, at a meeting in Berlin Society, described 2 cases, and that's where the naming of the disease as Myasthenia Gravis came. So his title was Myasthenia Gravis pseudoparalytica. Myasthenia in Greek means muscle and weakness, and gravis in Latin means heavy or grievous. Next, in 1934, they call it the miracle at St. Alphages. So here, Dr. Mary Walker had a patient with myasthenia gravis, and then one of the visiting neurologists, Dr. Brown, saw the patient, and then he thought the patient's symptoms resembled that of a curare poisoning. And then at that time, the treatment for curare poisoning was physostigmine. And then Dr. Walker tried physostigmine on her patient and saw remarkable improvement in the weakness. So this was probably one of the earliest treatments or therapies, which was discovered in the history of myasthenia. Next, surgical intervention like a thymectomy. The very first thymectomy was done in a patient in Zurich in 1911. And then in 1937, Blaylock reported improvement in myasthenic patients after performing thymectomy. Now, what is myasthenia gravis? So it is an autoimmune disease which affects the postsynaptic membrane at the neuromuscular junction. So it manifests as weakness, which worsens with repeated muscle activity. Usually, patients feel the best in the morning, and then eventually, as the day progresses, the weakness gets worse. Some of the clinical features include ocular manifestation. About 50 to 80% of patients with MG present initially with ocular manifestation. It could be ptosis, droopy eyes, or double vision. Most of these patients, at least 85 to 90% of these patients with only ocular manifestation, they generalize in the first 2 to 3 years of diagnosis. They can present with fatigue and muscle weakness, predominantly the proximal muscles of arms and thighs, facial weakness, and also neck muscle weakness. And as you can see in the picture, they can present with head drop as well. Speech can be affected. It can cause slurred speech or even nasal intonation. Swallowing can get affected with choking or nasal regurgitation of fluids. Shortness of breath, that's mainly because of the respiratory muscle weakness. Now, all these symptoms can get worse, and it can present as exacerbation, which is also called as a flare-up, or crisis. So there is a difference between exacerbation and crisis. So exacerbation involves worsening double vision, slurred speech, ptosis, or just overall generalized muscle weakness. They can have shortness of breath, but there is no respiratory failure. So if this exacerbation is left untreated, then it can progress into crisis. So crisis means there is severe weakness of respiratory, bulbar, or both of these muscles, which leads to respiratory failure. And the lifetime prevalence is about 20 to 30%. And Dr. Anderson will be talking about exacerbation and crisis more in detail in the upcoming lecture. So there are slight difference in the clinical features between the 2 major types of MG. One is acetylcholine receptor antibody-mediated MG, and we have the Musk MG. So as you can see, in Acetylcholine receptor antibody-mediated MG, the limb muscles, the neck extensors, and the extraocular muscles are greatly involved compared to Musk MG, where it's the bulbar, the neck flexor, and then there is mild involvement of the extraocular muscles. And muscle wasting is predominantly seen in facial and ocular muscles in Musk MG, whereas in the proximal muscles of arms and legs in the acetylcholine receptor antibody-mediated MG. So there is almost no involvement of thymus in Musk MG, and we'll come to this in the pathophysiology. Whereas in 65% of acetylcholine receptor antibody-mediated MG, we can see thymic hyperplasia, and in about 15%, we see thymoma. Crisis, recurrent crisis is more or frequently seen in Musk MG patients just because of the involvement of like the bulbar muscles. They tend to, or they're more prone for crisis, whereas in the acetylcholine receptor antibody-mediated MG, it's lower, but not absent. Coming to epidemiology, the incidence is about 20 per 100,000 population in US. 10% of these can have only ocular symptoms, and it's called as ocular MG. There is a bimodal peak incidence. So first peak is in the third decade and predominantly seen in female. And the second peak is between 6th to 7th decade and predominantly seen in males. So female to male ratio is 3:1 before the age of 40, and at puberty, between 40 to 50 years, it's about the same, equal incidence. More than 50 years of age is predominantly seen in males, especially in European population. And then there is a juvenile MG, where it's seen in children less than 8 years of age in Japan and China. So some studies have also shown that MG is more prevalent at the equator and then decreases as we move away from the equator, which again implies that there might be an environmental factor as well contributing to the development of MG. So LRP4-MG, this is another antibody. I'm going to come to the details of it in next few slides. It's seen in about 7 to 33% of patients who don't have acetylcholine receptor antibody or Musk antibody. So these are called as double seronegative myasthenic patients. And that's the incidence in Poland, about 33% of MG patients, in Greece 27%, Netherlands 26%, and in USA it's about 10%. There is no specific geographical pattern seen within Europe, or there's no similarity to the pattern between the acetylcholine receptor MG or Musk MG when we compare the LRP4 MG. So risk factors, like why does, some patients, why do they develop MG? So two things, yes, there is predisposing genes and also interaction with the environment. So those are the two things. They postulated that it could result in development of MG. Again, it's seen in about 35% in monozygotic twins. They can develop MG. If one has an MG, there's a chance other developing, and then in 5% in the heterozygous twins. And also there is a genetic variation in in the promoter region of the ChRNA1 gene, which encodes for the acetylcholine receptor alpha subunit. And this, if that variation is seen, then it does increase the chance of one developing MG. So there are certain dysregulated microRNAs, which again predisposes one to develop MG, sex hormones, which we see the difference in the gender, incidence, and also with age, and also infections. So what happens normally at a neuromuscular junction? So here, so this is the axon of the motor neuron, and then this is the axon terminal. And then this is the muscle membrane here, the motor end plate, and this is this whole thing is the neuromuscular junction. So when the action potential reaches the axon terminal, the voltage-gated calcium channel opens, and there is influx of the calcium ions into the axon terminal. Now, these are vesicles which contain acetylcholine. So once calcium is released inside, these vesicles attach to the axonal membrane, and then acetylcholine is released into this space here, synaptic cleft. And then this acetylcholine attaches to these acetylcholine receptors. These are ligand-gated acetylcholine receptors on the muscle motor end plate. And there is influx of sodium, and this generates the action potential, and then the action potential propagates through the muscle fiber, and then the muscle contracts. So now that happens. After that, this acetylcholine has to be cleared out of this space. It can't be continuously activating the muscle. So that's where we have this acetylcholine esterase, which is kind of like a clearance mechanism. It kind of cleaves acetylcholine and clears it out of this area. So this is what happens normally in the neuromuscular junction, and this is just an electron microscopic picture where you can see these little axons with axon terminal, and then these are the muscle fibers. So for the neuromuscular junction to work or function normally, there are a lot of different proteins and ion channels which have to work in synchrony for it to function normally. As you can see here, we have the acetylcholine receptors, and then rhabsin protein kind of anchoring it into the muscle cytoskeleton. We have the Musk here, the LRP4, agrin, CoQ, the ryanodin receptors. We have the potassium channel, calcium channel, and then all these muscle protein. We have actin, myosin, titin, cortactin, and there's many more muscle proteins. So all of these is required for a normal neuromuscular junction to function. So what happens in myasthenia? So here we have, I'm going to talk about the acetylcholine receptor first. So what you can see is these are nicotinic acetylcholine receptors of the muscle is the most common autoantigen in myasthenia gravis. Now the anti-acetylcholine receptor antibodies are detected in about 80% of patients with MG, and they're polyclonal. That means the epitopes of most of these anti-acetylcholine receptor antibodies are conformational, and also they have this main immunogenic region, which is present within these acetylcholine receptors. And it's really formed with some of the amino acids of the alpha subunit, and it's present in the central core of this acetylcholine receptor receptor itself. So there are three different mechanisms which are identified in regards to which this acetylcholine receptor antibodies can cause the pathogenesis of myasthenia gravis. So one is by activation of the complement. Once they bind to the receptor, they activate the complement, and then they form the membrane attack complex. And these membrane attack complex then damage or cause damage to these receptors as well as the muscle membrane. Next, we have these acetylcholine receptor modulating antibodies, which when they attach to these receptors, it results in increased internalization and then endocytosis and degradation of these acetylcholine receptors. So they're kind of destroyed after they get endocytosed and degraded. So their density over the muscle membrane reduces. And then we have these blocking antibodies, where these antibodies attach to the acetylcholine binding sites on the receptor, and then they block the attachment of the acetylcholine on these receptors. So anti-acetylcholine receptor antibodies that targets the acetylcholine receptor alpha subunit are found to be more pathogenic for Mg than the antibodies which target other acetylcholine receptor subunits, and their epitope basically pattern influences the disease severity. So it's a thought that, like depending on what the antigenic region is and against which the antibody may be formed might affect the severity of the disease presentation in individual patients. Next, we have the Musk protein, which is a transmembrane single subunit protein. So this is Musk. Clustering, the main function of Musk is clustering of the acetylcholine receptors. So it has to interact with the agrin LRP4 complex, and that activates the Musk protein, that's muscle-specific kinase, and then it kind of recruits the acetylcholine receptor onto the motor end plate where it is close to the nerve terminal. So Musk antibody is seen in about 1 to 10% of patients with MG. And these antibodies belong to IgG4 subclass. And since it's IgG4, they are unable to activate complement, and they are unable to induce antigenic modulation because they are mainly monovalent. So that's the reason they don't activate complement or induce, they don't cause antigenic modulation. Anti-Musk antibodies mask the binding sites on the Musk that allows interaction with its binding protein, including LRP4 and CoLQ, and therefore inactivates the function of Musk. Only anti-Musk specific IgG4 titers are significantly correlated with the disease severity. Now, one of the proposed theory, again, is there is class switching between IgG4 and then other subclass, which may be involved with the fluctuation and also disease severity in these Musk patients. Next is LRP4. This is also a transmembrane single subunit protein. So this is the LRP4 here. And it's LRP4 agrin complex, which activates the Musk and eventually results in acetylcholine receptor clustering or recruitment. Anti-LRP4 antibodies are found in about 19% of patients who are double seronegative. That means they don't have Musk antibodies or they don't have acetylcholine receptor antibodies. Okay. So next we have agrin. This also binds to LRP4. It's over here. It binds to LRP4. Dystroglycan, laminin, and it mainly helps in maintaining and regeneration of the neuromuscular junction. It is unclear whether anti-agrin antibody play any pathogenic role in human disease. Again, we don't have like commercial tests available to look for anti-agrin antibodies, but we do have for anti-LRP4. CoLQ, this is over here. Basically, mutations in CoLQ gene can lead to myasthenic syndromes. But again, antibody against CoLQ, we don't know whether it has any pathogenic role or not. But some myasthenic patients do have antibodies against CoLQ, but we don't know whether the role of those antibodies. And then we have this Kv1.4. This is a potassium channel which is present in muscle membrane. Antibody against the alpha subunit of this voltage-gated potassium channel, Kv1.4, in the skeletal muscles is seen in patients with MG. The same channel is also present in axonal membrane as well as endocardium. So there is a small subset of MG patients in Japan who present with severe MG as well as cardiac complication. Again, it's unclear whether it's solely because of that antibody against that channel versus is it a coincidence? So it's unclear. And there are a lot of other intracellular proteins which kind of, against which antibodies can be formed, and these are called as striational antibody. Most often it is associated with thymoma and in late onset MG. Again, these antibodies are against titin, ryanodin, myosin, actinin, filamin, and there's many more proteins. But the two important ones are anti-titin. It is the largest protein. It stretches throughout the muscle membrane. And it's a marker for thymoma in early onset MG, and it has a sensitivity and specificity of about 90%. Anti-ryanodin is antibody against the calcium channel in sarcoplasmic reticulum on the, in the muscle. Again, it's a marker of thymoma and indicates severe MG. So usually we do send for striational antibody when we do workup of the MG patients. And this is just a picture of all the proteins and the known antibodies in patients with MG. Here you can see the acetylcholine receptor. We have the Musk, we have the LRP4, agrin, colq, titin, ryanodin. But as you can see, there is a lot more protein and different, components which form this nerve and muscle junction. So that kind of raises the question, seronegatives, it may be some other antibody or something else affecting a different part or a different protein of the neuromuscular junction itself. So that's yet to be studied, discovered. So next is the function of thymus. So normally, what does thymus do? So it's a T cell educator. So what it basically does is there are self-antigens, that means proteins within our body, and these recognition of these self-antigens in the thymus is through a mechanism called as autoimmune regulator. So these autoimmune regulator basically expresses these self-antigens on the thymic epithelial cells. And whenever T cells recognizes these proteins or self-antigens, they go for negative selection and undergo apoptosis, and they don't come into the peripheral circulation. But there are some self-reactive T cells that do escape this, and that's called a central tolerance, where it eliminates those self-reactive T cells. And some of those T cells, self-reactive T cells, they escape that central tolerance and enter the peripheral circulation. But there is, again, peripheral tolerance. That means the immune system kind of keeps a check on those self-reactive T cells peripherally also, where they undergo apoptosis, or they kind of enter a state of energy or inactivity, or it gets suppressed by the Tregs. So as you can see, some of these tolerant T cells, they pass the thymus and then they enter into the circulation. And some of the autoreactive T cells, they undergo central tolerance, and some of them enter into the peripheral circulation and undergo peripheral tolerance. So that's the function of the normal function of thymus. So in MG, we know thymus is dysfunctional, or it's not functioning normally. So what happens here is, the tolerant cells, they pass through. The autoreactive or the reactive cells, even they pass through. And then the peripheral tolerance and the central tolerance are impaired. And that results in the generation of the antibodies and induction of the autoimmunity by these peripheral autoreactive cells. So about greater than 80% of acetylcholine receptor antibody early onset MG, they show enlarged thymus. In about 10 to 15% of late onset MG, they have a thymoma, that's a tumor. There is almost no thymic involvement in patients with Musk MG. It's mainly because of the pathogenesis or the mechanism. It does not trigger immune system. It does not activate complement system. It mainly acts specifically on the Musk protein in the neuromuscular junction. So that's why there is no involvement of thymus in Musk MG. And this is another nice slide which kind of talks about the entire process, basically the epithelial cells which presents these self-antigens. And then if the T cell basically recognizes it, it undergoes apoptosis, and that's the central tolerance. And the ones which bypasses the central tolerance enter into the peripheral circulation. But there is peripheral tolerance as well, like we discussed. And then the ones which escape as well, or if there is dysfunction of this peripheral tolerance, then that kind of results in induction of autoimmunity and then MG. So that's the reason why in any patient with MG who have a normal thymus gland or a enlarged thymus gland or thymoma, it is recommended that like they undergo thymectomy to prevent, or avoid this process. And classification of MG, there are different classifications, but this was the one I thought clinically it's much better. We have the early onset, late onset based on age. Early onset is less than 40 years, usually female predominant, typically present with ocular manifestation and can get generalized. There's thymic hyperplasia, and there's acetylcholine receptor antibody mediated. Late onset, usually more than 40 years, males predominantly. Either the thymus is normal, atrophic, and again, acetylcholine receptor antibody positive. But same late onset with striational antibody and acetylcholine receptor antibody, that's the thymoma-associated MG in about 10 to 15%. Musk MG is usually younger age of onset, 20 to 30 years, predominantly female. Bulbar respiratory muscle weakness is predominantly seen, and it's more frequently associated with crisis. And we have ocular MG that's mainly affecting the ocular muscles, not generalized. And we have the double seronegative MG where there are no detectable antibodies, but these double seronegative, they can have anti-LRP4 antibodies, so even that's something we send if these acetylcholine receptor and Musk antibodies come back negative and they have symptoms of MG. So this is the diagnostic algorithm where when we see a patient with clinical features or pattern of myasthenic weakness, then the blood work, the electrodiagnostic studies, which we do, and then also it's CT or MRI of the chest for screening for thymic involvement. Yeah, so some of the diagnostic tests which were done, which we don't do it, it's routinely in our clinic. So it's the edrophonium or the tensilon test. So basically here, IV test dose is given to make sure there's no hypersensitivity or reaction. And then we see the improvement in either in ptosis, double vision, or dysarthria assessment before the injection and after the injection is done. The side effect of this, it can cause bradyarrhythmia, cardiac complications, so atropine should be handy, and because of these side effects, we do not do this in clinic. We have better blood work and antibody assays available now. IcePack test, yes, here IcePack is applied for 2 minutes over the droopy eye or the over the ptotic lid, and this results in improvement of the ptosis. It's mainly because of it inactivates the acetylcholine esterase at that low temperature, and then acetylcholine tends to be there for a longer period of time in the neuromuscular junction, so the muscle stays stronger, or like eyelid opens up. And the blood work includes acetylcholine receptor antibody binding, blocking, modulating, striational, Musk, LRP4. I also include anti-titin and voltage-gated potassium channel antibodies as well. CT and MRI of the chest, mainly for evaluation of thymus, if it is normal or there is thymic hyperplasia or thymoma. And electrodiagnostic studies with repetitive nerve stimulation. If we see decremental response of at least greater than or equal to 10% in multiple sites, then it's suggestive of a neuromuscular junction compromise. Also single fiber EMG. Not all institutions do single fiber EMG, but that's also one of the electrodiagnostic tests which is done, and we measure jitter in single fiber EMG. And these are the list of drugs which, I know this is just a small list of drugs. There is in Myasthenia Gravis Foundation website, and also we give a card, to our MG patients in the clinic, which has like all the drugs which we need to use in caution, or some of them are contraindicated. So these are just some of the commonly used like antibiotics and some of the cardiac medication, psychoactive neurological meds and immunoactive meds and others. Like one of the things we have seen is like, magnesium. Patients come in with like low magnesium, and then if they're myasthenic patients, and then we load them up with like 2 grams IV magnesium, and that can definitely cause worsening of symptoms. So that's really have to be cautious about magnesium. And some of the special considerations is during pregnancy, new onset MG can occur during the first trimester or in the immediate postpartum period. In about 66% of MG patients, it results in worsening of their MG symptoms in the first trimester. 20 to 30%, they note improvement in the second and third trimester, mainly because of immunosuppressed state of pregnancy itself. Severe exacerbation with respiratory insufficiency can happen 3 weeks postpartum. And in one of the study, they kind of correlated this with the drop in the alpha-fetoprotein levels. That's something to keep in mind in myasthenic pregnant women, especially postpartum. Treatment during pregnancy is individualized. It's mainly case by case. Pyridostigmine, steroids, plasma exchange, IVIG can be used during pregnancy, but again, it's case by case and in close monitoring and with clearance from their obstetrician. So I know this is a very busy slide, but it kind of shows we have come a long way from like 1600s to 2021. I gotta add 2 more years here. So the green arrow basically shows the discovery milestones in myasthenia, like discovery of the antibodies and thymus involvement and complement involvement, all of those in the pathogenesis. And then the surgical approaches are in this orange triangles. And then pharmaceuticals and biologics are all the blue triangles. And we have the blood-derived treatments like plasma exchange, IVIG, are all in the red. So as you can see, for a long time, there was nothing other than just, like pyridostigmine, physostigmine, there was pretty much nothing. And it's only in the recent years, in late 1900s is when IVIG plasma exchange came into picture. And then it's really in 2000s is when all the others, mycophenolate, rituximab, tacrolimus, and we have the newer eculizumab, belimumab, and the FcRn, that's the complement inhibitors. Those are all much recent development. And I know Dr. Green is going to go over this in detail in her lecture. So there is still a lot to know about MG and discover about MG, and it keeps continuing. Yeah, and that kind of concludes my talk. And thank you. Questions?
Thank you, Dr. Schroff. So we welcome our attendees to post questions and poll everywhere, and we'll be able to answer them. One question I had, and what has been posed, is in terms of the thymus, do you decide to remove it only if you see something on the CAT scan and MRI? Should everyone have their thymus taken out?
So it is said that every patient pretty much with MG, if they're less than 60 years of age, then even if it is normal, especially if, say, if a patient is not responding the way they're supposed to, or they're refractory, or they're having a lot more exacerbations than, like one would expect. So difficult to treat refractory MG, even though they don't have any thymus on CT, those are the patients, I would want their thymus gland or the fatty tissue in the mediastinum to come out. Just because thymus gland might not be just like one gland in the chest, it could be dispersed within the thymic tissue, can be dispersed within the fatty tissue in the mediastinum, which might not be clearly seen on the CAT scan as like one gland. So in those instances, yeah, I do recommend getting the thymus gland or the fatty tissue in the mediastinum out, just to get those thymic tissue if they're dispersed in those instances. Yeah.
The second question is, what if you have a patient who you suspect has myasthenia, but the studies, the antibodies, the EMG electrodiagnostic testing are normal, or they don't help you? How do you do you treat them? How do you manage them?
Yeah, so say they're double seronegative, LRP4 comes back negative, EMG is normal, and pretty much all the workup comes back normal, but they are presenting to you as with typical, or like so some of the symptoms of like myasthenia gravis. Then yes, I would give them a trial of treatment and see if they would improve, whether it is with just pyridostigmine or with steroids. And sometimes, we might have to do even like plasma exchange, or like a short course of IVIG to see if that really helps their symptoms or improves. And sometimes giving that short course of treatment in itself is like, it's like a diagnostic test, which kind of tells us, yes, there is something going on, but yes, we can't see any results, or at least known antibodies that we that are available to test. But yes, there could still be many more antibodies which we don't know of against the neuromuscular junction protein. So yes, I would give them a course of treatment to see if they improve, and if they do, then I would continue the treatment, and they will be seronegative MGs. Yeah.
Thank you. Yeah. There is a question in poll everywhere. Mm-hmm. Can we use PCSK9 inhibitor to reduce LDL in MG patients, one of the newer hyperlipidemic agents, something like Repatha, possibly?
Yeah, so, okay, so this is for hyperlipidemia, for lipid profile. I need to look at the mechanism of action of that PCSK9 inhibitor, what really is the mechanism of action. As far as I know, statins, some of the myasthenic patients, they tolerate fine, some of them they don't. And then the other injectable form of the injectable forms, yes, my myasthenic patients have been tolerating those medications fine. So I need to look at the mechanism of action of the PCSK9 inhibitor. Yeah.
So I think that it's Repatha. So
okay,
it works. Okay. Yeah. So we've looked at this, and we actually recommend it for our patients versus statins, just like you said.
Yeah.
Because it works on signaling pathways in the liver, mm-hmm. which are involved in cholesterol synthesis. And so I agree with you, statins we're very concerned about. Yeah. But with this particular new agent, it's well tolerated by our patients.
Yeah. So yeah, if it is Repatha, then yeah, they're tolerated, definitely well in MG patients. Yeah.
Yes. Any other questions from our attendees? And thank you for submitting them. Thank you, Dr. Schroff. Yeah. Excellent talk.
Thank you. Thank you.
Okay, thank you so much. I just want to encourage all of our attendees out there, please post your questions even during the presentation. We can look at them, be prepared to answer them, and even if the presenter has finished, if a question comes up, please post it and we'll make sure to answer that. Again, be aware of any bias that you detect and let us know immediately. And now I'd like to proceed with our next speaker. This is Dr. Ashley Anderson, who is relatively new to our program and department, but has really done quite an excellent job with our patients. She is a Morehouse graduate and trained in neurology at the University of Florida, and then joined us as a fellow and has now joined our department as an assistant professor of neurology. She takes care of a number of patients with myasthenia gravis and has a wonderful bedside manner. She is going to talk about a very important topic that is important for not only patients, but especially for us as healthcare providers. Welcome, Dr. Anderson, who will talk about the management of acute exacerbations and crisis from the perspective of the healthcare provider. Dr. Anderson?
Thank you, Dr. Green, for that wonderful introduction. And hello and welcome to everyone. Thank you so much for joining us for our 12th annual Myasthenia Gravis conference. I am here to provide some information and some guidance in regards to the management of myasthenia gravis exacerbations as well as crisis, and looking from the healthcare provider perspective. So, all right, got it. I'll do it from here. All right, so before we get started, I think we'll kind of all start with a little bit of history. And we're going to take a brief look. So I think we've already talked about Dr. Willis here, who was kind of the first to really describe a case of myasthenia gravis using this quote that he had under his charge, a prudent and honest woman, who for many years hath been obnoxious to this sort of spurious palsy, not only in the members but also in her tongue. She for some time can speak freely and then readily enough, but after she has spoken long or hastily or eagerly, she is not able to speak a word, but becomes mute as a fish, nor can she recover the use of her voice under an hour or two. Then it was about maybe 200 years or so later that Dr. Samuel Wilkes described a similar condition in a female patient that had slow movements and bulbar palsy. But it was not until around 1895 when Dr. Friedrich Jolly coined the term myasthenia gravis. So he used the Greek term for myasthenia, which means muscle and weakness, as well as the Latin term gravis for heavy or grievous. And so I mention all this history to say that while the identification of myasthenia gravis is not new, but we have, as Dr. Schroff showed in her last slide, come a very long way. And so the condition now is not as grievous or heavy as what it once was, and hopefully that message comes through with all of our talks today. So the objectives of my talk today will be to first kind of define the difference between a myasthenia gravis exacerbation and a myasthenia gravis crisis, and look at the different signs and symptoms that can occur. We also look at potential provoking factors or triggers for an Mg exacerbation, how an Mg exacerbation should be evaluated, and then different management options that are available, the prognosis, as well as the prevention of these exacerbations. So as we move forward with the talk, we first want to make sure that we define accurately what we're discussing in regards to an exacerbation versus a crisis. So when we talk about a myasthenia gravis exacerbation, this just means a worsening of any Mg symptom or symptoms. And that can range in the type of symptom, whether that is double vision or blurry vision, or whether that is issues with speech or swallow. And it can also range in severity into how much ptosis the patient is experiencing, how bad their swallowing is affected. Then an exacerbation can result in a crisis. And this is an exacerbation that leads to respiratory failure, which could require intubation or ventilatory support, which could be non-invasive as well. Now, this can occur in about 15% of MG patients, usually within the first 2 years. About 74% of patients who end up having an MG crisis usually occurs within the first 2 years after symptom onset. The different signs and symptoms that can be involved, as mentioned before, are going to be ptosis, which is just drooping eyelids. Some patients may also experience some issues with ophthalmoplegia. There could also be neck weakness, including flexion weakness, as well as patients may experience head drop. There could be facial weakness, and that could include both ocular, buccal, labial weakness. And mention again, blurry vision, double vision. And then it could be limb weakness. And so the patients may also mention that they have more fatigability in their limbs. So they may have more difficulty performing the same tasks that they would normally. They may report difficulty rising from a seated position, and they may have more difficulty raising their arms, or their arms get more tired with performing activities that require them to lift their arms. Other signs and symptoms include issues with dysarthria, and this could be slurred speech. It could be more nasal sounding speech, and as well as dysphagia, where they have issues with their swallow, and that could include issues with swallowing to both liquids and solids. And they may, again, this is something we definitely want to monitor and notice whether or not they're mentioning whether this is getting worse. It may start with, and it's mentioned, some coughing after drinking thin liquids, or having more difficulty with thicker foods or heavier foods like steak or chicken, or sometimes even more grainy foods. They may also mention difficulty managing secretions, difficulty with either they notice any excess saliva or difficulty with swallowing their saliva. And then, of course, they can have shortness of breath, and that shortness of breath can be with activity. And again, they may mention for an exacerbation that they're now becoming more short of breath in activities to which did not bother them previously. Or they could mention shortness of breath even at rest, and then, of course, orthopnea. And so when we look at what patients are kind of more likely to experience a crisis, there are certain factors that we see. So patients that are older, patients that have late onset myasthenia gravis, patients that have a higher Myasthenia Gravis Foundation Association class, and we'll see that on the next slide in regards to what that means. And then patients that have other medical comorbidities, including other autoimmune conditions. And patients with myasthenia gravis were more likely to have other autoimmune conditions, more often thyroid disease, lupus, as well as Sjogren's. And there was a 2015 study that looked at various patient characteristics and found that, as we can see here at the bottom, that patients with late onset MG, as well as were positive for some type of autoimmune disease, were more likely to experience a myasthenia gravis exacerbation. And again, just quickly talking about, when we're talking about the Myasthenia Gravis Foundation of America clinical classification, this is a way for us to kind of objectively put the patients into a class based on severity of symptoms. So starting here with class 1 and going down to class 5, which is the most serious, and then there's several subclasses in between. When we talk about exacerbation, one of the first things we look for is a reason why. We want to find a cause. The vast majority of patients come in with a myasthenia gravis exacerbation we typically find a cause. More often than not, it's going to be infection, and then that is followed by medications as well as surgical procedures. There was a 2018 study that was performed to look at the different causes of myasthenia gravis exacerbation. And what we see here is that it ranges, but if we come kind of down to this part here, we see that, so VPI and VNPI, so VPI stands for vaccine preventable infections, and then VNPI stands for vaccine non-preventable infections. And so you see that accounts for a large part. And then the other part here is this medications that should be avoided or used with caution in patients with myasthenia gravis. And so we see there, so when we talk about vaccine preventable infections, those are things like the flu, conditions like the flu, and then vaccine non-preventable infections. For example, a patient comes in with a UTI. And we will go over again, as Dr. Schroff mentioned in her talk, about certain medications which should be avoided or used with caution in patients with myasthenia. And so here we have some of those, and the list is longer. Again, this is kind of coming from the Myasthenia Gravis Foundation of America, who has a more extensive list than this as well, and then some of these were already mentioned. One of the newer ones that we're seeing a little more frequently now are these immune checkpoint inhibitors, such as pembrolizumab, which we're seeing in our patients who are coming in with as far as the treatment of certain cancers. And so we are seeing those patients. We already kind of talked about the issues with magnesium, and the primary thing that we run into with our patients that come in with this worsening is that they're on an antibiotic for some type of infection, for example, a UTI. And then it's just very important that the provider who is treating that knows the patient has myasthenia gravis and knows that there's certain antibiotics that need to be avoided if possible. If the patient has an infection that can only be treated with certain medications, and we run across that a lot, then it's important that the patient is followed more closely by not only their primary care provider, but also their neurologist, and aware of any potential signs that could result in exacerbation, so we can make sure to intervene quickly. One of the things that we'll talk about a little bit later as we go into how we manage myasthenia gravis exacerbations is the use of steroids. So steroids is up here as a medication to use with caution in patients with myasthenia gravis, but as I'm sure most of us know, this is one of the mainstays for myasthenia gravis treatment. And so this is one that is important for the treatment, but close monitoring, again, is something that is important, and there are different both outpatient and inpatient dosing regimens that are often used. So in evaluating a patient that's coming in with a myasthenia gravis exacerbation, the first thing, as we all know in medicine, is to get a good history. Get an idea of when the symptoms, started, when they were diagnosed with myasthenia gravis, what symptoms they had when they were diagnosed, what was their first presenting symptom, were they mostly ocular, mostly bulbar, and what current treatment regimen are they on for their myasthenia gravis. Then you want to, as we just spoke about, I try to identify and evaluate for any particular provoking factors, whether that's certain medications, whether that is an infection, whether they had a recent procedure, or even a recent life stressor that could be causing some reason for them to have this exacerbation. The evaluation also needs to especially if they're presenting to the hospital, then a swallow evaluation is important. Even if the patient is saying that they're not really having that much issues with their swallow, again, if they're coming into the hospital, there's likely something that is possibly something there that we need to evaluate for, and the patient should not be eating anything or drinking anything until they're cleared by a speech-language pathology evaluation and the physician. Then again, what we're definitely worried about when a patient comes in with an exacerbation is their breathing. And so we want to do bedside pulmonary function testing. And this includes two different aspects. One is either a NIF, or a negative inspiratory force, or a maximum inspiratory pressure, sometimes may also be seen. And we have the normal values there for both of those. And the importance here is that this measures diaphragm function in patients with myasthenia. And as we know, again, that's a muscle, it can also become weak. And so these are this is definitely a parameter that we look at for impending respiratory distress or failure. And then patients may also get a functional vital capacity, or FVC, and we see what the normal value is there. If those tests aren't readily available, and sometimes they are, or if you're seeing a patient in clinic who you're concerned about evaluation as far as their breathing, a single breath count can be performed just at the bedside, where you ask the patient to take in a very deep breath, as much as what they can, and count out loud at a normal to fast pace and see how high they can get. We usually prefer patients to get around 20, and this is a very rough estimate of about 2 liters on the FVC. When we talk about management of Mg exacerbations, as we talked about before, an exacerbation could be of any symptom. And so when it's minimal or mild, these patients may not necessarily have to go to the hospital. And so that can include if they're having worsening ptosis, vision changes, or just some mild extremity weakness. They may also complain of some mild shortness of breath, especially with certain activities. Again, it's important to obtain the history and get the course of how long this has been going on, exactly what they're experiencing. And then it's important to see the patient. I know now we have transitioned a lot of our care to virtual, given the current climate. So a virtual visit can oftentimes give you what you need. You can hear the patient's voice. Is it sounding more slurred or nasal sounding? You can see what if they're using any kind of accessory muscles to breathe. So a virtual visit is also fun. You can also try to have them stand up and walk and see what they're doing, or get up from the chair, or hold their arms out in front of them to see how much they're able to do that. An in-office visit, of course, is also where you can do the similar workup and see what a patient is actually experiencing. And through either a virtual or in-office visit, there can be adjustments made to the patient's treatment regimen, which includes perhaps increasing the dose or the frequency of their pyridostigmine, perhaps placing them on or increasing their dose of their steroid, or adjusting their IVIG or PLEX schedule, or looking at possible adding on another treatment option. It is important, though, when we're talking to patients about if their symptoms of worsening, sometimes patients will recognize that Mestinon, their pyridostigmine, works well for them, and they will try to increase the doses on their own. It is important that that is not done, and that the neurologist is aware of any dose changes there, because a cholinergic crisis can occur if the patient is taking so much Mestinon to try to maintain, to where they end up having the opposite effect, to where now they have more weakness, increased secretions, and now are and have more shortness of breath, and now have worsening problems. If the treatment adjustments there are not effective, then there is a very low threshold for the patient presenting to the emergency room hospital for evaluation. For moderate to severe exacerbation, these include when patients are complaining of issues with progressive dysphagia and or progressive dyspnea or orthopnea, these patients need to go to the nearest emergency room. So it's important that when we discuss this with our patients that they realize that even if their neurologist works at hospital A, but they live closer to hospital B, then they need to go to hospital B to make sure that their breathing is doing okay. That is the important. Even though they may want to be at the hospital where their neurologist is located, it's important they go to the nearest emergency room for evaluation. Once a patient presents, they will need to have care and monitoring in an intermediate care unit or in the ICU setting. We want to make sure that we stop any contributing medications, and this can include pyridostigmine or mestinon. This can cause issues with increased secretions, which the patient may have more difficulty handling, and cause more issues for problems with possible aspiration, and make the use of non-invasive ventilation more difficult. You want to make sure that there's regular monitoring of their respiratory function with the use of the NIF or the FVC. It's important here that we're not tiring the patients out by monitoring them so often that their muscles, their diaphragm is getting tired and they're getting more fatigued, but that we're also keeping track of where they are in regards to their respiratory function. And that's usually averaging about 4 to 6 hours, depending on the patient as how often you want to monitor their respiratory function. And if possible, we want to if possible, you want to start non-invasive ventilation, such as a BiPAP. This can prevent or delay intubation in about 50% of patients that have myasthenia. As mentioned previously, sometimes patients may have a lot of issues with secretions, or their respiratory status may be so severe that unfortunately we do have to move to intubation. And then we also want to mention the importance of cardiac monitoring in these patients. Now, as mentioned before, these patients are going to be going to an IMU or ICU setting to where they are on continuous cardiac monitoring. But it's important to recognize that patients that come in with a myasthenia gravis exacerbation, about 15 to 20% of those patients may have developed severe arrhythmias. Now here we have a proposed kind of treatment or algorithm for the management of severe myasthenia gravis exacerbations. And there are similar algorithms to this, but what I really liked about this one is the last kind of phrase here on the slide is to never give up. And the reason I like this is because myasthenia gravis exacerbation is treatable. And while some patients may not respond to the initial treatment and may need more prolonged or aggressive treatment, the majority of patients respond and do well. So we definitely do not want to give up. And we'll go through a lot of these different steps in the upcoming slides. So to that end, the two treatments that we primarily use are going to be intravenous immunoglobulin, or IVIG, as well as plasma exchange, which is also abbreviated as PLEX, or is also called apheresis or plasmapheresis. So when we talk about IVIG, so IVIG is a purified pooled preparations of the IgG antibody from the plasma. And the exact mechanism of how IVIG works in modifying Mg crisis or exacerbation is not clearly known, but there are several mechanisms looking both at both complement activation or function and different sorts of immune responses. Patients are often treated with a dose of 2 grams per kilograms of weight, usually divided over the course of 4 to 5 days, and this is given through a peripheral IV. Plasma exchange, or PLEX, works by directly removing humoral factors such as autoantibodies, immune complexes, complement, and other nonspecific inflammatory mediators. Usually this is given about 5 sessions or so that are typically scheduled every other day. And the issue here is that there may be a central venous catheter that may have to be placed. When we talk about IVIG, usually it's a very well-tolerated medication, but there are certain situations that you want to make sure that we are aware of. So we want to use IVIG with caution in patients that have certain cardiac and vascular histories, including those patients that have a history of DVT, and in patients that have issues with kidney disease. And we can see here on the other side of the screen, we talk about different types of possible side effects of the IVIG. The most common is going to be headache. Some patients may also experience chills and body aches, and then chest pain. We already talked about the risk of possible thrombosis, which is why we use it in caution with patients that have a history of DVT. Aseptic meningitis is also a potential issue. And moving down to the anaphylaxis, and that's only occurs with IgA deficiency. Sometimes we will get an IgA level prior to starting IVIG. Most patients, it is not an issue unless they're severely deficient in IgA. And then, of course, there could be some type of auto transfusion reaction or allergic reaction that can happen with the medication. When we talk about plasma exchange, we want to use in caution in patients that have issues with infection or have a high bleeding risk. And the reason why is that while the plex is washing out all of the bad antibodies, we'll call them, from the Myasthenia Gravis, it is also washing out some of those good antibodies that the patient has to use to fight off the infection. It is also washing out some of those clotting factors, and so patients that have a high bleeding risk, we need to make sure to use for caution. Again, mentioning it may require central venous catheter placement. Because of the requirement for the venous catheter, there may be certain types of catheter-related events that can happen. While plasma exchange should be euvolemic, meaning that the patients will not really taking out any fluid, it is a potential for having some issues with hypotension. Again, it can cause some issues with some different electrolyte imbalances, issues with hypocalcemia, and again, it can still have a reaction. There's albumin used during this process as well. So when we look at the effectiveness of whether it's IVIG versus plasma exchange, there have been several studies performed that compare the two and have found that the effectiveness clinically is very similar. Now, oftentimes in practice, we may use plasma exchange first, typically because it has a more rapid effect. Now, if a patient receives plasma exchange and they have an incomplete response from that, then IVIG may be given subsequently. And then, of course, a decision on whether or not to use plasma exchange or IVIG really is based on the patient's clinical characteristics, the safety and tolerability of that medication or treatment in the patient, if this is not their first exacerbation, what they've responded to previously, and other patient-specific factors. This is a recent study from 2020, excuse me, for looking at patients that were admitted for myasthenia gravis crisis that required either days in the ICU or mechanical ventilation. And what it is showing with these bar graphs here is that if we're looking here, for example, for this one, looking at days in the ICU, and so here's the patients that received plasma exchange, and here's the patient that received IVIG, that these patients that had to receive either or did about the same in regards to their response and in regards to the days that were required for mechanical ventilation. What we see here is that patients that required both IVIG and plasma exchange had a longer ICU stay, a longer time on mechanical ventilation, as would be expected because their symptoms were likely more severe. And then going now to what we kind of briefly mentioned earlier, which was talking about one of the mainstays in treatment of myasthenia gravis is the corticosteroids. And so this is often a part of the treatment plan for a myasthenia gravis crisis. As mentioned previously, this must be used with caution, as rapid administration or very high doses of steroids may cause worsening. This is less likely to occur in patients that are being treated with IVIG or plasma exchange. Oftentimes what we'll do if a patient is, for our non-intubated patients, we'll typically start lower doses and then try to up-titrate by a certain amount, either 5 or 10 milligrams every 2 to 3 days, and typically the goal is around 60 to 80 milligrams per day. We're trying for our non-intubated patients to avoid that transient worsening that may occur when we're introducing steroids, and we want to make sure we don't make things like their breathing worse, especially so that they don't have to get intubated. With our patients that are intubated, we're often more able to be a little more aggressive because they have that ventilatory support, and so higher initial doses may be better tolerated. And so when we look at the prognosis, the majority of patients who suffer from a myasthenia gravis crisis will make a full recovery. Primarily what we see here is that we have complications that can occur from intubation or mechanical ventilations that are often the cause of a more prolonged ICU stay. In that same 2020 journal article I mentioned earlier, the risk factors associated with a more prolonged ICU stay, which is described as more prolonged ventilation support, and ICU stay, and that is described as greater than 15 days, are similar to those that are associated with the increased risk of exacerbation. And so that's going to be older age, patients that have late onset myasthenia gravis, and those that have a higher myasthenia gravis foundation association class. In addition, patients that have certain medical comorbidities are also more likely to have some complications. The mortality it varies from study to study, but typically ranges about 5 to 12% in regards to the mortality from a myasthenia gravis crisis. And this is more often from infection, and again, more common in patients that have certain medical comorbidities. And while this is still something that we want to make sure that we get this down, and so that there's zero mortality if possible, this has definitely improved from even the 1960s, to where the mortality rate of myasthenia gravis was about 40%. And we've noticed these improvements due to earlier identification of patients with myasthenia gravis and the use of non-invasive ventilation as part of the support for myasthenia gravis, in addition to the advancements in treatments that we'll hear about shortly. And so what all our goals are is, how do we prevent this? How do we prevent our patients from having an exacerbation or crisis? And while we may not be able to do that for all of our patients, we definitely want to do the best that we can to keep our patients out of the hospital and going through this. And so part of that, the first thing is this early and accurate diagnosis. And so getting patients evaluated by a specialist when they're coming in with signs and symptoms that seem to be consistent with myasthenia gravis, and we can undergo the different treatment plans that diagnosis course that Dr. Schroff mentioned in her talk, that is important to make sure this person can accurately diagnosed. And then these patients also need close outpatient monitoring. So once the patient is diagnosed and established with myasthenia gravis, a diagnosis of myasthenia gravis, want to make sure that we monitor those patients closely, especially early in the disease course. As mentioned earlier in the talk, patients are more likely to have a myasthenia gravis exacerbation or crisis within the first 2 years after symptom onset. Then the next thing is what we're doing here today, patient and provider education, so that there is early identification of any type of exacerbation symptoms, so that patients can hopefully be managed more conservatively and not have to be go into the hospital to get intubated. And that starts with just knowing what to look for. And then treatment. So there are various treatments, and we saw that the treatment were kind of nothing for a long time, but now there has been this huge boom recently in regards to the different treatments that are available, and Dr. Green will talk about all of those. And it's important that patients are on the appropriate treatment, and that may not always occur with what we start the patients on initially, but again, that's when that close monitoring comes in to make sure that treatment adjustments, if necessary, can be made to try to obtain symptom control. And management of any type of medical comorbidities. So patients that may have other type of autoimmune conditions or other type of medical conditions, making sure that those are appropriately managed and that they have the appropriate specialists or with management with their primary care to follow those along. And then also vaccination. So in that same 2018 study that I mentioned earlier, it states that there was no Myasthenia Gravis exacerbations that were associated with vaccinations. And it is so important that our patients obtain vaccinations, whether that's for the flu or for COVID-19, the vaccination and the booster, in order to try to prevent contracting COVID-19 and especially all the respiratory complications that can come with that. So with that, I will conclude my talk. I appreciate your time and attention today and willing to take any questions.
Thank you, Dr. Schroff. That was an excellent talk. We do have some questions on Poll Everywhere, and I'll post those in a minute. But one thing I was going to ask you to possibly speak on is the absolute and the relative contraindications in terms of those medications, the medications that can cause myasthenia. Mm-hmm. So one question that I often get is, what about those that aren't absolutely contraindicated? And you don't know if it's going to make your patient worse.
Absolutely, that's a great question. So the kind of, I guess, rule of thumb there, as I mentioned before, oftentimes our patients will come in, and, for example, with an infection, or they may be seen in the hospital and having Mg exacerbation with an infection, and this is the only antibiotic that can treat that infection. Then I think there, as mentioned before, that we are, it is definitely used with caution. We want to make sure we need to clear the infection so that we can get the exacerbation under control. And more of our outpatient medications, we try to work with the patient's primary care provider, as well as, or any other specialist, about trying to find alternatives if possible. If no alternative is available, then lower doses, the lowest tolerable dose, if possible, and then of course, again, close follow-up.
Thank you. You do have a couple of questions.
Mm-hmm. So I guess I'll start with the first one. Can you describe the blurred vision and double vision? Is it common for the vision to be blurred or double in one eye and progress to the other eye? So most patients, when they come in and complain of blurred vision, it's usually with the blurred vision with both eyes. However, when they are mentioning double vision, usually it's going to be, again, it's both eyes. So it's going to be binocular, and then usually if they cover one eye or the other, they'll mention that their double vision will improve. And oftentimes the double vision may be two separate images. Oftentimes patients may say that they'll see either an outline or the vision is, or the image is a little bit offset or just kind of right next to each other, as opposed to, something two separate. And then the blurred vision, just like that, just blurry vision. Patients have decreased kind of visual acuity, and you'll know oftentimes this will fluctuate. So this is a way to know. Sometimes, we say blurred vision, which is general and can be caused from a variety of different reasons, but patients will say, my vision is fine when I wake up in the morning, and then as the day goes on, or they may say as I'm watching TV, as I'm sitting at the end of the day trying to read my book in bed, I'm noticing that my vision is getting blurred, and again, they're putting more strain on those muscles. And then the second question is asking what type of arrhythmia is commonly found in patients with Mg exacerbation. The type of arrhythmia usually is in ventricular arrhythmia, but other arrhythmias can be seen. It's just the kind of autonomic instability sometimes that can occur in these patients that are going through a crisis.
Okay, and there was actually a question for Dr. Schroff as well, which was, can you provide information on why thymectomy is not routinely recommended for age over 60?
All right.
So there was a recently, a few years ago, there was a study in NEJM with thymectomy in myasthenia patient. They did a randomized controlled, trial where they enrolled patients up to, initial enrollment was up to age 60, and then they increased it to 65 years, where they did see that and then there were two groups, like one was prednisone alone treatment for MG, and then they looked at the other group is prednisone plus thymectomy group. So what they saw was in the group, and then they divided the group as according to the age, which was less than 50 and more than 50. And what they saw was the thymectomy was effective in reducing the prednisone dose and also getting the patients more into better controlled MG and into remission in the group which was less than 50 years of age. And in more than 50 years of age, there was not a whole lot of improvement, even with thymectomy, whether it was in reduction of the prednisone dose or in remission of MG. So that was one study. And then there was another smaller study in 2019 where they looked at 30 patients, and then their group was like less than 65 and more than 65. So more than 65 was the elderly population, less than 65 was the younger population. And then they did see that in the elderly group, there were like 9 patients, out of which 5 of them did not show no improvement. And even among the other 4, none of them went into complete remission despite thymectomy. So that's the reason, like why we say in elderly or more than like 60 years of age, even though like, yes, you might do like, thymectomy, it might not be helpful. It might not help in getting them into complete remission. And thymectomy is an invasive procedure. So if it's not showing the benefit, then why put an elderly patient, through the procedure? So that's the thing. Yeah, so that's why we kind of say. But yeah, the other point I wanted to make is if it's thymoma, that's a tumor, then no matter what the age is, it has to come out because it's cancerous or it's tumor. So when we say thymectomy, that's mainly for like normal thymus and enlarged thymus gland. That's when we give the age cut off. But if it is a thymoma with a tumor, it has to come out. Yeah.
Thank you so much, Dr. Schroff.
Thank you.
I'm going to ask Dr. Anderson to come back. We finished it a little early, so we welcome more questions and poll everywhere. We do have additional time. But the question, or what I wanted you to speak more on, is the initial dosing of steroids and what the risk of that is. We use steroids, but for our healthcare professionals and even our patients, some advice.
Absolutely. And so that is a great question, a little bit of a loaded question because it really does depend on the patient and what the patient kind of presenting symptoms are, I would say, as far as where we typically start. So as on the outpatient basis, starting a patient typically on around 10 milligrams at first for their steroid, and then typically increasing by about 5 milligrams or so every couple of weeks until they're on a target dose. And again, that could be up to about 60 milligrams or so as an outpatient. Now, what we are concerned about is, oftentimes our patients may present with more bulbar symptoms, more issues with their swallowing, more issues with their breathing. And that is definitely when we get more concerned, and where the adjustments to where typically still around the 10 milligram dose, 5 milligrams possibly, depending on what the patient is presenting with, and then again a slower titration of that, to where that may be either taking a longer time between the 5 milligrams, whether that's 3 weeks or even a month, or to doing it more like at 2.5 milligram dosing. So it really does kind of depend, but that's usually kind of the mainstay of starting around 10 milligrams.
I 100% agree, Dr. Anderson, and the reason I bring it up, and I'm not sure our attendees are thinking about this, is that what we often see, and I'm sure you can attest to that, is that when a patient is progressing as an outpatient, often their physician will they'll start them high, versus, as you've said, 5 or 10. And sometimes they'll even give them intravenous steroids. And the reason why I asked Dr. Anderson to speak on that for all of us is that the steroids can actually cause the myasthenia to get worse to the point of exacerbation or crisis. So I thank you, Dr. Anderson, for answering that.
And just one other point about that. So we mentioned that to the patients, just let them know too. So we educate the patients that you may feel worse before you feel better. And so we often use steroids, and that's still a mainstay because they're readily available, because they're cheap. And so but we have patients know that if they do not get better, or if they see their symptoms getting worse, again, that goes along with the patient education that I mentioned, that they definitely need to let us know, so that adjustments. And then talk about things like plasmapheresis, plasma exchange as different options. So the patient should, that kind of worsening that may happen, or that not getting better, should only last a few days. So this should not be something to where once they start the steroids that they never get better, or they never get over their symptoms worsening. And so that's when we need to think about different treatment options.
Exactly. Thank you, Dr. Anderson.
Thank you. Appreciate your time.
Well, that concludes the first half of our session today. We're going to go ahead and end with our break. I do invite you to continue posting your questions if you need clarification for anything we've presented, or just something comes up later in preparation for the next presentation. I ask that you would post. In the breakout session, we have a virtual sponsor, a hall where, and I just want to thank our sponsors, UCB and Alexion, and a number of others that are listed, which we'll highlight and recognize at the end of our session today. So they have poster halls for you to visit. In addition, we have 2 videos that are going on continuously. One is a video of different patients in our population who volunteer to talk about their disease and the course of their disease. And I think it's valuable to listen to those patients, to see what their daily life is. And we're going to show that for both days of conference during the break, because I think it brings some real humanism to the disease that we're presenting today. The second video is one that we recorded last year. Dr. Anderson was kind enough to really give a little podcast about how to navigate in the ER. Dr. Schroff is going to talk about that tomorrow in greater detail, but for those who just want a snippet of that, we welcome you to access that as well. So again, I thank you for attending this morning. We will see you in a little less than an hour. We will get started at, well, 12:30, I believe. What time? 12:30. We'll see you then. Thank you. to our health professional education conference regarding myasthenia gravis. I'm Dr. Erica Green. I'm the course director, and I'm proud to bring this to our healthcare professionals for the third year in a row. Again, just some housekeeping. Please push the link for Poll Everywhere so that you can post your questions either from the prior lectures or in anticipation of the upcoming lectures today, including my own. Again, all financial disclosures have been submitted to the CME, but if you find that there is any evidence of potential bias or promotional bias, please let us know immediately. So I am actually going to give the third lecture, and I'm going to talk primarily on the emerging and the most recent advances in the care of myasthenia gravis. I think that we are in an era in the past decade where we have seen an explosion of new therapies for a number of different diseases, specifically in neurology, and also that includes myasthenia gravis. We have one of the first FDA-approved treatments of myasthenia, and probably we'll see the approval of a few more in the next few years. So I'm excited to begin this lecture. So I think this quote from Marie Curie is very appropriate. She was quoted as saying, "Nothing in life is to be feared. It is only to be understood. Now is the time to understand more so that we may fear less." And because of that, by greater understanding of the pathogenesis of the disease, what causes it, what causes things to progress, and particularly to myasthenia, we've been able to identify targets for therapy that will expand our repertoire for treatment. Dr. Schroff and Dr. Anderson did a great job at really discussing the history, how far we've come from the earliest descriptions of the disease as a fluctuating weakness affecting speech, swallowing, vision, and breathing, to now what we know of myasthenia today, this being an autoimmune disease, which is still considered a rare disease according to the Orphan Rare Disease Act, but is no less serious in that 70% in the 1600s died from this disease, and although we have progressed in ways to management, we still have a persistent 5 to 8% of our patients who will succumb to this disease. Again, I won't spend too much time on the history. I think it's been adequately presented earlier today. But at first, it was felt to be something circulating in the blood by Jolly. A female family practitioner, Mary Walker, first discovered the role of drugs such as what we now use as mestinon or pyridostigmine, similar types of drugs that helped our patients. We discovered that pregnant women delivering their children could transmit these circulating factors to their children and cause similar symptoms. But it wasn't until the 1960s and early 70s that we discovered what that circulating factor was. And this is just a nice picture. Dr. Schroff showed a similar picture earlier today showing the nerve fibers ending in end plates on the individual muscle fibers. This is a nerve. These are the end plates of the nerve connecting directly to individual muscle fibers. This is where the problem is in terms of myasthenia gravis. I always like to acknowledge our mentor and current chair, Stan Appel, who early in his career as a physician scientist was part of the group that discovered what that circulating factor was in patients with myasthenia gravis based on animal studies and utilizing blood from patients. They discovered that the circulating factor was an antibody that came from patients' blood, which interacted specifically with the acetylcholine receptor protein complex on muscle, which Dr. Schroff went into great detail about. He noticed it in 70% of the patients tested, which is very close to the number of patients who have this antibody who have myasthenia gravis. But even then, he implicated the role of the thymus gland, which Dr. Schroff mentioned today in her talk, and its role in initiating or propagating this disease by the release of autoreactive T cells, which instead of being discarded by the immune system, are left to roam and target this acetylcholine receptor and thus cause disease. This is a high-powered, magnified picture of a neuromuscular junction. To the left is normal. This globular structure with all of these small bags or vesicles is the end plate of the nerve, which I showed you and Dr. Schroff showed you, filled with acetylcholine chemical. Normally, these are released into this very small space and interact with these darkened areas here on the end of the muscle, sort of outlining it. These are thousands, or if not more, of acetylcholine receptor complexes, which when activated cause the muscle to contract. Because the immune system is attacking these protein complexes, it causes destruction of the muscle end plate, loss of the acetylcholine receptor complexes. You no longer see the dark stain, and you see a total disruption of the muscle cytoarchitecture, and this is what we see: high-powered, magnified visualization of the neuromuscular junction. So in terms of therapy, we've also come a long way. Dr. Schroff mentioned about the first series of thymectomies, which were done both in the UK as well as in America around the same time, where they noticed that when they were taking out the thyroid gland for patients with Graves' disease, they would also take out portions of the thymus just to clean it up because it seemed to be enlarged. And they noticed that the patients got better, not only in terms of thyroid disease, but in terms of this fluctuating weakness, which was myasthenia gravis. They looked at dialysis, lymphatic drainage, but it wasn't until the Korean War, where there was the development and use of constant care units, critical care tents and units, that we started to see a great impact on the survival of patients with the use of ventilators. Then plasma exchange was seen as beneficial in the late 70s, and now we have well over 10 to 15 different used treatments for myasthenia gravis. So I've listed them here, and I could talk about each one in great detail, but for the sake of time, I'm really going to concentrate on what's new and what's emerging. But I will just sort of talk about them a little bit. For my patients, I typically divide the treatments into that which is just for symptoms, and I always use the analogy that when we get the flu, Tylenol and Motrin are used for the symptoms of pain and fever, but don't treat the actual infection. Similarly, in myasthenia, Mestinon basically allows more of the acetylcholine to stay around between the nerve and muscle and compensate for the loss. It's symptomatic. But the vast majority of our treatments, like other autoimmune diseases, are immunosuppressant. Mainstay remains prednisone at moderate to high doses. We also have chemotherapy, oral transplantation drugs, and drugs that we've borrowed from rheumatology, such as azathioprine or Imuran, cyclosporin, these are some of its brand names, mycophenolate mofetil, even cyclophosphamide, which has been used well in the past, tacrolimus, and many of these have been used in other autoimmune diseases as well, in combination often with prednisone. Then we have some infusion therapies, rituximab, which is an antibody against B cells, immune cells which can transform into antibody-producing cells. and seem to have a role in the Musk positive patients that Dr. Schroff mentioned. And there is some data, although not strong and not definitive, that there's a subgroup of acetylcholine receptor positive patients who respond to this therapy. I'm going to talk about eculizumab very soon. And of course, Dr. Schroff and Dr. Anderson mentioned the role of IVIG and plasmapheresis, especially in patients who present with exacerbations and crisis, and both have been found to be equally effective in those instances. And then thymectomy. So this is just a rough graph to show where we've come. So to the y-axis is the percent prevalence. The x-axis is decades from the 1900s to the 2000, early 2000. And this orange declining sloped line is the death rate or the mortality rate. And this yellow ascending line is the survival rate. And as you can see, they crisscross, and it correlates over time with the use, identification, or development of treatment and surgical treatment options, from thymectomy to something like mestinon or pyridostigmine, tracheostomy, ICU care, and then a host of treatments which I just alluded to. So we've seen a remarkable improvement, although there is still a small percentage of patients that, despite these advances, have a risk of death. So I'm going to touch a little bit on the groundbreaking international thymectomy trial. As Dr. Schroff mentioned in her talk, the thymus is activated abnormally in the majority of patients with acetylcholine receptor positive myasthenia. We don't seem to find that same pathology with patients who have Musk positive myasthenia, but we know that the thymus gland is very important for the development of one's immune system. And in myasthenia, we know that that thymus gland has abnormally released T cells which will attack self. So the study was done to prove or to determine if, by really removing the thymus, does it improve myasthenia gravis. And so this was a 6-year study of 126 patients at multi-international sites, and they were randomized to either undergo a thymectomy via transthoracic approach alone, or thymectomy with steroids. And what they found was that, if you look at the diagram, to the right top, the blue line being prednisone alone, and I'm sorry, that should be prednisone alone, not thymectomy alone, prednisone alone, or thymectomy and prednisone together, that by having a thymectomy, that the degree of muscle weakness was less. In other words, these patients were more strong with both being on prednisone, but one group having a thymectomy. And this was evident months to ultimately 3 years, and now we're several years out, obviously, with the same benefit. In addition, at 3 and 5 years, the dose of prednisone is less. The use and dose of some of those chemotherapy drugs that I mentioned are less in these patients, and the risk or the incidence of crisis, hospitalizations, and exacerbations are low in patients who are acetylcholine receptor positive, who have their thymus gland taken out. I will add that we did have a question earlier about thymectomy in someone over 60. The study did not show the same benefit of a thymectomy in patients over 60. Prednisone was just as effective. And so we typically are thinking of a thymectomy, as Dr. Schroff mentioned, in someone whose disease is poorly controlled, in a young patient under the age of 40 who is acetylcholine receptor positive. And so Dr. Schroff showed a much more full slide. This is a little less full, which shows the evolution of therapy from the 1900s again to now 225. And we have one of our first FDA-approved treatments for myasthenia, eculizumab. But we have a host of treatments prior to that which we still use, as well, of course, as mestinon, pyridostigmine. So I'm going to try to make this simple because we talked about the immune system. We've talked about the thymus gland. We've talked about T cells, and I've even mentioned B cells. This is an autoimmune disease. And so the immune system has decided that the acetylcholine receptor on the muscle is a foreign epitope and needs to be destroyed. And so what we know is that this allows many areas to target the immune system, because the immune system is quite complicated. It's like the military, many branches, many levels of hierarchy and power, and many roles, and they all work together to fight the enemy. Similarly, our immune system is set up to identify, patrol, and take out the enemy, and to study the enemy. So this diagram is showing you that the two players are the T cell, the B cell, and these two cells communicate with each other. The T cell is the autoreactive T cell released from the thymus, which then communicates with the B cell to become activated, to turn into an antibody-generating cell called a plasma cell, directing its antibodies against the target, here being acetylcholine receptor, but possibly also the Musk receptor and some of the other receptors that Dr. Schroff mentioned. This leads to a cascade of signals and events, such as the deposition of protein called complement, which destroys the muscle, a lot of inflammation, cytokines, chemokines, and there are many areas that have been studied in myasthenia targeting pathways that either block the communication between the T cell and B cell, such as belimumab, block the signal from a T cell to the B cell of a cytokine such as tocilizumab, as well as treatments directed at other cytokines which activate these cells that have been used in other autoimmune diseases. And then we have those monoclonal antibodies, one of which I've mentioned to you, rituximab, but there's been some interest in some multiple sclerosis medicines, such as Ocrevus, trying to block activation of this B cell from turning even to a plasma cell or even being an activatable cell. But for the sake of our talk, I'm going to focus on where we've made the most progress and where a lot of attention and research has taken place. And that is the role of complement in myasthenia gravis and the role of these anti-acetylcholine receptor or other protein antibodies. This is a table. It's not meant for you to peer at, get details, but this was a table cut in half, actually, from a recent paper about all the treatments in neuromuscular medicine, and this was just the section on myasthenia gravis, which tells you a lot about what's going on in myasthenia. So we have these top three, eculizumab, zilucoplan, ravulizumab, which are against complement. We have drugs and agents directed at the cycling of antibodies in myasthenia. And there's also been some work looking at stem cell transplant as well as T cell therapy, very similar to what's been done in cancers. So again, just so that we understand where we're going, we have another illustration of the immune system now really targeting what's going on close to the muscle. So as I've mentioned, you have the T cell here, which has decided that this receptor or other receptors is abnormal. It then sends signals, chemokines and cytokines, to a B cell, which then is activatable and turns into an antibody-generating cell, which is targeting these proteins on the muscle. For at least one of those types of antibodies, which Dr. Schroff mentioned, the binding antibody, it also activates a host of proteins called complement, which are normally a part of our immune system and very important for fighting certain types of infections. And this complement sort of attaches to the muscle and the receptors like Scud missiles. And I use this phrase, sort of blows it up. And so you get a marked destruction here. As well, these antibodies, which serve as homing missiles for this complement, also get recycled. They get recycled in tissues. So they're taken up, they're cleaned up, and then they're recycled back out to attack again. And that may be why such things as plasmapheresis can only last so long unless we continue it. IVIG may not last as long because antibodies are being developed as well as recycled. So these are the two areas where we are doing a lot of research. We probably will have more than one drug approved in the next 2 years based on these targets for therapy. So again, there are drugs in the pipeline that are being studied right now. I'm going to talk about a couple of them directed at the cycling, the recycling of these antibodies and how to stop that, how to stop releasing these antibodies back into the system, as well as drugs that are directed against complement. And what's not listed here is one that's already FDA approved, eculizumab. So let's talk about complement. As I said, complement is basically a group of many different proteins which each protein activates the next set of proteins in series, maybe a little bit in parallel. And by activating a cascade of these increasing proteins from C1, C2, C3, they have a role in inflammation, response in anaphylaxis, but I think most importantly, this series of proteins which activate and cleave each other end up activating a group of proteins called the membrane attack complex made of 5B, 6, 7, 8, and 9. And basically these proteins come together, such as transformers, transform and create a pore, a hole in cell membranes to cause them to rupture and die. This is a normal immune response that we need to fight such things as Neisseria meningitis, streptococcal pneumonia, and those encapsulated bacterial infections. But this pore also occurs in patients with myasthenia gravis on the skeletal muscle, particularly those patients who have complement, which I've shown you in an earlier picture, and those are patients which we now know are acetylcholine receptor positive. And this is a picture of how these proteins come together starting at C5, 6, 7, 8, and 9, and you get this pore. And I think this picture really highlights how there are all these holes that are just punched into the cell membrane, causing rupture and loss. And so you see that on a microscopic level, this is a fairly destructive process. And this is, again, high-powered, magnified photography, a photomicrograph of the neuromuscular junction. Again, if you remember, this globular structure is the end of the nerve terminal with all the vesicles of acetylcholine. You have a very complicated undulating muscle. The black stain here is the acetylcholine receptors, but it also is significant for immunoglobulin binding. And then this stain, which is pointed out by the arrowheads, is where complement is located. This is showing you immunoglobulin deposition, complement deposition, where the acetylcholine receptors are located. So that's a good segue to talk about eculizumab. which is the first FDA-approved treatment in the treatment of myasthenia gravis, autoimmune, acetylcholine receptor positive type, which is directed at the complement. This was a double-blinded, randomized, placebo-controlled trial with an extension open-label part, and its primary endpoint was to determine pre-treatment and post-treatment if the level of the patient-reported activities of daily living were affected, the MG-ADL. This was one of the first studies in neuromuscular medicine, and specifically in myasthenia, for which it was FDA approved based on the patient-reported measure. This was a 26-week study, and patients were recruited if they had not the mildest form of the disease and not the most severe form of the disease, but were in that broad range of some eye symptoms, maybe some speech symptoms, all the way to someone who was not intubated but could very well be soon. The patients had to be acetylcholine receptor positive, and most of them had to have failed a prior therapy over a year before entering, and they had to be on at least one or two of those immunosuppressant therapies or modulating therapies, which I mentioned. And there is a score that they use called the Mg-ADL score. Again, I mentioned it here. So they had to be symptomatic. They had to have some impact on their activity of daily living. So they recruited patients who were being treated, but whose disease was not controlled or was not in remission or minimally affecting them. This is just a quick slide to show you the Mg-ADL. It's a patient survey. They take it themselves, and a patient will rate if their talking is impaired, chewing, swallowing, breathing, getting up from a chair, brushing their teeth, eye movements, and how often, if at all, it occurs. The next measure that is used in this study and many other studies of the like is how it impacts their quality of life. So there's a series of questions that a patient will answer, not at all, very much all the time, based on their frustration, their limitation, their depression, their trouble, their sense of being overwhelmed. And again, this carries weight in terms of the impact of our treatments and is now used as outcome measures for these studies. And I will just take an aside to say that even in the clinic, we are utilizing these metrics with our patients as they come in to see us regularly so that we can monitor how our treatments, how their disease are impacting these measures in their lives. It's a very sensitive indicator. Now, the quantitative Mg score is a combination. It's really a little bit of what the patient reported from their ADL score, as well as what the doctor measures. Actually, that's the composite score. This particular score is all physician measured. So it's more objective. Physicians have to be certified as reliable. And so this is a more objective measure because it doesn't take in the subjective patient report. And it's also used often as a secondary measure now. So going back to the eculizumab study or the REGAIN study, and let me just say that many of these study slides that I've showed you are being used or modified from the slides given by Dr. James Howard of North Carolina, a leader in myasthenia gravis research, complement pathology, who came to speak to our group last year, did a phenomenal job. So I definitely want to give him credit for leading in this research and making this information available to the community often throughout the year. So with that said, when they looked at the patients who were enrolled in this study, it was about 62 in the eculizumab group, 63 in the placebo group. So we had 125, 126 at the initial. And as you can see, the majority of them had had the disease with a wide standard variation of about 10 years. So these were not novel patients. Their ADL score was above 6, actually 9 to 10. The physician-measured score showed a lot of disability, and their quality of life was also greatly impacted. Dr. Anderson mentioned the classification, which is just based on the severity or the burden of their disease, and these patients were not very mild nor extremely severe in an ICU, but you can see that a number of them were in the 2 to 3 range, so still affected significantly. In terms of between the two groups, what treatments they were on, 50 and 54% were on 3 or more of those medications, infusions, or treatments that I mentioned on the previous slide. And a higher group, over 90% were on at least 2. So these were patients on standard therapy who had had the disease for a significant amount of time, who were still impacted in their day-to-day life by activities of daily living, quality of life, and even in the physician measure of burden of disease. So very important group. And so this is just another slide just sort of discussing their history before they were enrolled. Many of them had been on IVIG, exchange, not as many. 74 to 80+% had had an exacerbation in the past. Up to 20% had had a crisis. That means intubated. Hospitalizations, again, this is not a novel, mild group. These are the patients we see in clinic. And so these were the results of this study. So in the red is the placebo group. This is a 26-week study. The blue is the, I'm sorry, forgive me for that. The blue line is the treatment group on eculizumab. The red line is the placebo group. And this is the onset of the study when they were randomized, double-blind. And what you see, looking at the Mgadl score, that the treatment group had a marked improvement within the first 2 to 3 weeks of their activities of daily living after infusion, and they were able to maintain that throughout the 26-week study. Now, there was a significant placebo effect, which we see in myasthenia gravis, but it did not reach the statistical improvement of the treatment group, although that placebo effect remained. At the end of the 26 weeks, all patients received eculizumab, including the original placebo group. And once the placebo group was able to receive the drug in an open label extension, you see the same slope here. And now these two groups are overlaid. This variation here is due to a decreased number of patients at this stage of measurement. This is what we call minimal manifestations, and this is someone who has myasthenia, but really on standard evaluation, on activities of daily life, there's really no evidence that they have the disease. They may tell you at the end of the day, my lid droops a little bit, or on examination you may find a little bit, but in day-to-day activities there's really no evidence. These are patients with minimal manifestations of disease. And this is highlighted by the yellow. So these are patients who were in the study. This is the open label study, and the blue represents improved during exposure to the medicine. The pink is the placebo, so this is the first 2 weeks. You see there was a placebo response, and even there were patients who had a minimal manifestation, but we see a far greater improvement and a far greater number who had minimal symptoms in the treatment group. When all comers received the drug, you see an even greater number of patients on who were originally placebo and drug and who were all on placebo actually having minimal manifestation of disease, as high as 69 and 53% in the original two groups. And we saw this clinically in our practice. They looked at the number of exacerbations and hospitalization rates in these patients. And when you look at exacerbation rates, as Dr. Anderson defined, in pre-study, before they were enrolled, the model-based event rate was up to 105.2. During the study, the placebo effect dropped it down to 79.2, but this is not at all, this is very statistically significantly lower in the treatment group, down to 27.7 from 105.2. So that was the drop in exacerbations, and even more importantly, in MG-related hospitalization, before treatment, the patients had a 79.4 event rate, and it went down to 13.5 in the treatment group. And so the number of times, Dr. Anderson talked about how we treat exacerbations. We treat it with rescue therapy, IVIG, plasmapheresis. And just very quickly, you see that the use of IVIG or plasmapheresis in this group is much lower than in the placebo group. And even in the responders, literally down to 1. And of course, in that group, there were about 39%, 38% of patients who did not respond to eculizumab as quickly as you saw, or at all. And so you see that they did have a number of events, although still half of that of the placebo. So although they were not defined as responders based on the study criteria, there was some impact of this treatment that was better than even the placebo. In terms of side effects, very well tolerated. 2 patients died in the open label, not related to the drug. The most common side effect is headaches or pain, just general pain in about 10 to 15%, usually managed with analgesics. Because complement is important to protect us from infections such as Neisseria meningitis, patients must be fully vaccinated to be on this drug. It started on vaccinations to even begin the drug, and people who give this, doctors who give this medicine must be registered in order to be prescribers. So now I'm going to switch gears to another complement inhibitor, which is zilucoplan. And zilucoplan is another formulation of a complement inhibitor, which has a different half-life, and it has been studied in a phase 2 study, and this has been published in, again, generalized myasthenia, acetylcholine receptor positive patients. This time in the phase 2, they looked at the physician measure, the quantitative Mg, and these patients had to at least have a 12 or greater, which was there was a burden of disease. They had to be on stable doses of their standard therapy, and of course, like the other study, they had to be fully vaccinated because of the risk. The endpoint, again, was this time the physician measure, the objective measure, and then secondarily the patient reported measures. And they were looking at 2 doses of this drug, a 0.1 and 0.3, with a 1-to-1-to-1 randomization with placebo. Again, this was a phase 2, so a smaller sample size, and then an open label extension, which is still being looked at. And when you looked at the baseline characteristics, again, they were very comparable. These patients in all 3 groups were on pyridostigmine. The majority were on steroids. The majority had been on IVIG, and a significant number, especially in the treatment group, had thymectomy. So this was a little uneven. Again, this is a phase 2 study, but you can see that these were symptomatic patients on treatment, similar to the last study. And then, again, just going back to their baseline, they had a burden of disease that was comparable. There were more whites than non-whites, more females, with the exception of the 0.3 higher dose. And then again, their disability, the measure, the burden of their disease as measured by physicians in the study was quite high. And so this is just looking at the impact of zilucoplan on complement. So the higher the dose in the blood versus the 0.1. But in a dose response, you see that the higher the dose was associated with lower complement inhibition. The 0.1, which was the lower dose, also lowered the complement inhibition, not to the same degree. And of course, placebo did nothing to the complement activation. So you can see that these drugs were very effective at inhibiting complement activation. Now, when we look at its effect on the ADL and the QMG, we see that in the QMG, that's the physician measure. In the blue is the placebo, and the 0.3 is the red, and what you can't see is the 0.1 is the orange, and so they're both overlaid, and you can see that here the treatment group had a marked improvement. There was a placebo response with the blue line, the placebo group, but then there was a separation here as they got to almost 8 weeks and then almost to 12 weeks. In the open label extension, we see a similar drop in the treatment group, although not to the same degree. You can see the dose response difference here with the 0.1 and the 0.3, a little bit more with the 0.3. And then with the patient reported, we see a similar profile, marked improvement compared to the placebo. And then with open label, we see that all groups respond. Again, this was enough evidence to proceed with phase 3 study. And this is just, again, looking at the point improvement. To what degree did they improve? And I think you can see that there's a far greater number of patients who were on the highest dose who had the greatest points improvement compared to the placebo. So yes, there is a placebo response that we have to pay attention in myasthenia, but in terms of the degree of improvement, it seems to leave the placebo response behind, and we see that even with the drug, we're getting a significant improvement in function. And then we talked about the minimal symptom expression, a dose response in a very small phase 2 study, that the higher the dose, the greater the percentage of patients who had minimal symptoms at the end of the study. And so what we see here is that minimal symptom expression, whether it's in the eculizumab, this is just to remind you, in the double-blind study, far greater percentage of patients in the blue got to minimal symptom manifestation. And when they, in the open label, when all the patients were receiving drug, you see that those who were previously on placebo are now having an even greater number of patients who have minimal symptoms, as well as what we saw with this phase 2 study, that this has changed the course and possibly the history of myasthenia in those patients who we've been satisfied with a new normal of functioning but still very symptomatic. So I'm going to end talking about the antibody recycling drugs. These are treatments that target a receptor called the Fc receptor, which is important in sort of modulating the target of the antibody, and is very much involved in how it recycles back in the tissues and comes back out to be active again. So efgartigimod is now being studied as a modulator of this antibody recycling. This particular receptor on antibodies recycles the IgG, it attaches to cells, the antibody then goes into the cell and typically is then cleaned up in a lysosome and then is released back into the system to attack again. And what efgartigimod is a human IgG Fc fragment which interacts with this Fc receptor, okay, and it binds in the same way as this IgG binds to the cell, and it prevents it from being recycled back, and it's designed to keep the IgG inside the lysosome and then to be degraded and to be disposed of versus recycling back. So normally the Fc receptor on antibodies interacts, and is very important for it not being degraded but cleaned up and recycled, and efgartigimod blocks that Fc receptor in a way where it is then degraded and disposed of and never enters back into the blood. So this was a phase 2, again, double-blind, 1-to-1 study of 10 milligrams per kilogram of IV efgartigimod in myasthenia gravis patients. They looked at both acetylcholine receptor positive, but there was a small percentage of patients who were not acetylcholine receptor positive because antibody recycling is important for all autoimmune diseases with antibody-mediated disease, including Musk positive, antibody negative positive, or acetylcholine receptor positive. So they looked at a small percentage of those who didn't have this antibody as well. And they looked at, again, the self-reported ADL, and then they're still doing an open label extension to evaluate these patients. Again, the baseline characteristics, it's important to see that you have the acetylcholine receptor positive patients were the majority, and they were, had the disease for at least 8 to 9, 10 years, similar to the other studies. They had an impact on their ADLs, their function as measured by physicians. They were still had a burden of disease as measured by the MGFA class at screening. Many of them, at least half or more, had been previously treated. And at time of baseline, many of them were still on these immunosuppressant therapies. And you can see that about 19 out of the 84 were not acetylcholine receptor positive. So a small percentage, but there. And so what you see is that the primary outcome was what impact did efgartigimod have on the activities of daily living, at least 2 points or greater improvement. And for those who responded, that means within a week after treatment, 67.7% responded early in the treatment group compared to 29. When we look at the physician measure, which is more objective, we see a similar improvement. And this was 3 points or greater. So quite impressive phase 2 study. And the early responders were those who saw this effect within the first 2 weeks of infusion. And then we take a look at this graph again. We see the proportion of patients, again, a far greater number of patients in the treatment group who not only met the primary outcome of 2 points or greater, but then there was some percentage of patients, a third, who had 6 or 7 points greater improvement. And then you see how the placebo effect begins to wash out or falls behind, even more so for the objective measure, where the placebo response is less of a factor. And then even for those patients who end up with minimal symptoms, as I've defined, you see 40% in the treatment arm. How long did this response last? Now, with this particular drug, it wasn't on a scheduled cycle. They would load it up with weekly infusions, and then they would determine when the next infusion is based on worsening symptoms, change in ADL, no more improvement. So this might be a drug that we dose in an individualized way for our patients. But it's important to know that in this phase 2 study for the early responders, at 12 weeks or more, 34% still had a duration of response. The durability of response remained at cycle 1 and cycle 2. And you see the mean change from cycle. Again, no real significant mean change until it was time to retreat. And then when they looked at the mean percent change in the acetylcholine receptor antibody levels, or the IgG levels, you see that in the efgartigimod group, in the antibody levels, the acetylcholine receptor antibody positive patients had a marked drop in those antibodies because those antibodies were not being allowed to be released, as well as just the general IgG levels in the green significantly dropped with treatment, and then when it was time to retreat again or after the effect had worn off, you see that there was an increased rise. Generally, the side effects were mild to moderate, very well tolerated. The most frequent side effect in both the placebo and the treatment was headache, and infections, maybe a little bit more, but not statistically significant between the two. I just wanted to touch base on another receptor, FcRn receptor modulator that is now being studied in a phase 2 results. They've enrolled 68 patients. They're looking at the QMG. These are patients who are on treatment. Both anti-Musk and acetylcholine receptor patients are enrolled in this study. And so they are looking at several different doses and dose options. From 5 mg per kg every 4 weeks, 30, 60 mg per kg every 2 weeks, or 60 mg single dose compared to placebo with an open label similar to the other studies. And this is just some early results. Again, this is provided by Dr. James Howard of Chapel Hill, University of North Carolina, who is a leader in myasthenia gravis clinical trial research, who presented this last year, and I have the privilege of presenting it again. is that as you see with these doses, you see that, that the change in the ADL, this being the degree of change, was even greater with the 60 milligram single dose versus Q2 weeks. And then when they also looked at the change in ADL from baseline, again, this is day 57 out, that it was still significant for at least one or two of those doses. So we'll be waiting on that test, that study going forward, and those results. So I've presented a lot today, concentrating a lot on what has recently been FDA approved, the impact on disease, as well as what's coming around the pike. So this is a very exciting time for us and our patients. I think it's important to know that this is an era of targeted immune therapy as we learn the pathophysiology of these diseases, and that we potentially now have the opportunity to change the clinical history, the natural history of this disease in a way that we've not been able to do in the past. And so I think we'll have to identify more areas for target as we learn more. There are always challenges with cost and third-party coverage, which we're dealing with now. But I think we should look forward to a time when we can do precision, patient-specific medicine that really changes the nature of this disease and how we treat our patients. So I thank you for your time, and I am ready to take questions. So I'm going to see if anything has come up. All righty. When having electrodiagnostic studies performed, EMG, is it important to have the weaker limb evaluated, or is there no significance excluding coarse atrophy, which will affect? So I think this was a question that came earlier, but I'd be happy to try to answer for Dr. Schroff. So unlike muscle biopsies, where we try to choose a limb that's not too severely affected or not too mildly affected, we typically do standard muscles for repetitive nerve. We do the facial nerve, the accessory nerve to the trapezius, and the ulnar nerve as a standard to at least get more proximal and distal muscles. And there's really no indication to choose a more weak or a less weak, because if you find the decrement, usually we find it closer to the area that's more affected. It helps to diagnose the disease. It helps in the diagnosis. So I'm going to put the rest of these questions up and try to answer them. For MG patients, who've had a reaction, large raised erythematous areas on the abdomen, peeling of skin on palms a few days after IVIG, what treatments do you employ in a crisis? Yes, this can occur. It is a serum sort of complement or antibody mediated deposition. It is not uncommon in the outpatient and in crisis to get this very itchy, inflamed, torso-laden rash with IVIG. Typically, unless there's a contraindication, especially if IVIG is indicated, we treat with steroids, both topically and oral or intravenously. Even as an outpatient, sometimes our patients respond very well to IVIG, yet and still have this rash. And depending on the severity of the rash, we can manage it with steroids around the time of each booster infusion as an outpatient, maybe a small dose throughout topically. Sometimes it's so severe that it prohibits us from testing, or treating, I should say. So steroids would be indicated for that. So the next question is, some patients have had an Mg exacerbation, significantly increased muscle weakness, increased double vision after COVID vaccinations, especially after the second. What mechanism is involved? What can MG patients do prior to a third vaccine to decrease the possibility of another such reaction? So we're going to cover this for sure tomorrow for the patients, but this may be a healthcare professional. You know, the thing about vaccinations is even before COVID, we've also always cautioned and recommended our patients to be vaccinated, because the infection is typically worse than the vaccine in terms of tipping over their disease. As Dr. Schroff talked about, and Dr. Anderson, infection is a trigger to worsen the disease. However, that doesn't mean that vaccines themselves can't worsen it, because it does promote an immune response which is associated with inflammation, which can make the disease worse. Obviously, you want your patient as strong and you want their treatment optimized enough where you can mitigate that reaction. But statistically, when we look at the vast majority of our myasthenia gravis patients, the risk of the infection and the impact of the infection on their lives is far greater than the number of reactions we're seeing from the vaccine. Now, I'm doing my sample size. I've not had one patient with an Mg exacerbation with COVID, although I've heard reports, but it's in the minority compared to the benefit of the vaccine for preventing COVID in our patients, which I feel is more dangerous. In terms of treatment, you would support them, you would treat them as a myasthenia gravis exacerbation in crisis as you would anything else. And we'll have a panel on that tomorrow, so I welcome those to respond. The next question is, how often do patients receiving Soliris infusion have to be vaccinated? It's based on the standard CDC recommendations. I believe it's every 5 years. It may be shorter for older patients or more immunocompromised patients, but it's the standard recommendations of, I think it's ACP. Forgive me if I'm getting the acronym wrong, but there are standard recommendations which apply to our patients as well. There are 2 vaccines or 2 types of vaccines, the more common vaccination, which covers the majority of the serotypes, and then type B. Patients have to be vaccinated for both. Typically, they're separated by at least 2 months for each, but we can start infusion after they've received the first of the 2 sets for each. And so it's based on recommendations. In studies that included seronegative patients, was there significant difference in effect for these patients? Was there a significant difference in the effect for seronegative and positive patients? So we're talking about the efgartigimod study, which impacts the amount of antibodies that recycle. So the sample size wasn't large enough to say, but it would appear that the seronegative patients, which were not a lot, very few, responded like everyone else in terms of improvement. And again, that's a phase 2 study, which if you're not involved in research or you're a patient, is really the study that looks at dose and safety. So the sample size is small, and we need the numbers for it to be statistically significant. But the results would suggest that even in seronegative patients, where for the most part we know antibodies are there, we just can't detect them, this treatment would be a treatment for them. So that's exciting. So I see that's all the questions we have in the poll everywhere. I really thank you for your time. I believe it's time for our next. We're going to take oh, it's a break. Oh, that's wonderful, because I need a drink of water. So let's take a little break, and then we'll be right back at 1:30. Thank you. No, I guess what time should we be back? Thank you. So the wonderful thing about virtual is we can do these real time. So Dr. Cow, our next speaker, is coming on. So we'll introduce her in a few minutes. And until she's ready, are there any other questions in the poll everywhere? Dr. Cow is a Stanford Associate Professor of Pulmonology and Critical Care Medicine. She specializes in the use of ventilatory support for patients who have breathing issues, and actually has a special interest and expertise in patients who have myasthenia gravis and other nerve muscle disorders. So that is a rarity in the nation, and Dr. Cow was one of those experts. She has spoken for us last year, as well as at other neuromuscular conferences, about how to manage the breathing, as well as in a crisis, as well as when patients are not in a crisis. So she is a wealth of information. I also wanted to say that in terms of COVID, we know that this is very important. She's going to talk about COVID-related guidelines in terms of what's recommended in greater detail, vaccinations, treatments for COVID in myasthenia gravis patients, hopefully. And then tomorrow for the patient conference, we will end that session at about 1:55 with a panel discussion with all of our speakers, including Dr. Cow, who's coming in virtually from Stanford, about COVID variants and vaccinations. So I hope that you tune in for that. Again, please post your questions and poll everywhere. We'll be checking that even after the conference and would be happy to email you back or contact you if you leave that, if we have that information. Excuse me. And we will see if Dr. Cow has been able to connect. Are we ready to connect, Dr. Cow? So I think while we're waiting for Dr. Cow to be able to connect, I wanted to share a story of one of my patients who I had been treating for 20 years. She had had the disease since late adolescence, and at that time was in her 60s. And so for many of us who treat these patients who've had it for so long, and she had had a thymectomy many years before I saw her, and she was on a number of immunosuppressants therapies, from steroids, which she couldn't tolerate very well, cyclosporin, Cellcept, Imuran in the past, IVIG, plasmapheresis. We tried Rituxan, and she had a lot of other conditions, which, as Dr. Anderson mentioned, makes it a little harder. They have to be, you need to be in good general health, your patients, and they need to see their doctors. But we gave her eculizumab, or the newly FDA-approved treatment Soliris. And this patient's disease had permanently, or at least I thought so, limited her eye movements. So her eyes were permanently out of symmetry, and because of what myasthenia had done over the years. And I just figured that would never come back. I think most neurologists consider that when a patient has had it so long, it's a fixed problem at that point. Well, I was surprised to see that with eculizumab, her eyes were able to straighten up. And so as a physician who had never seen that before, this drug, and I'm hopeful that the drugs that are coming down the pike will have an equal, if not greater impact, we don't know, was very encouraging to myself and others in the community. So again, when I say we're in a new era of treatment and there's a lot of hope for therapy for our patients, I mean that sincerely. Is Dr. Cow ready? Okay, so why don't I allow you all to take a few minutes break, get a cup of coffee, a drink of water, check the mail. 5 minutes, okay. So we will meet back at, let's say, 1:40, exactly, 1:40 Central Standard Time. Please go and take a break, come back, and we look forward to finishing our conference at 1:40 p.m. Thank you. issues, but that's the nature of the game. It is my pleasure to welcome my professional friend and colleague, Dr. Michelle Cowell. Dr. Cowell, I've already spoken about you very positively in your role in neuromuscular pulmonary care and how often you've spoken with me and for me. So I've already introduced you very well. So with that, I'll let you take over. Thank you.
Okay, great. Thanks. Let me share my screen really quick here. Green for inviting me. This particular topic is dear to my heart. So I am going to talk about respiratory issues in myasthenic disease and management as well for the non-pulmonologist. So learning objectives today, I have three. The first is to highlight mechanisms of sleep disorder breathing and respiratory failure. The second is to discuss respiratory evaluation and management, and we will end with discuss the myasthenia crisis and ICU management. So just to begin, respiratory involvement in myasthenia gravis involves several categories. So the first is we know that there's impaired pulmonary function, and this primarily involves the diaphragm movement and weakness, but also involves other respiratory accessory muscles as well. There's also the bulbar involvement, which leads to sleep disorder breathing, and this is classically known as sleep apnea. So these patients, because of the upper airway obstruction from the bulbar weakness, they can develop OSA. And also, in the cases where there is diaphragm involvement, these patients will have REM and non-REM sleep hypoventilation. And moving on, there is also the airway clearance issue. So these patients have impaired cough and an inability to clear their airway from abdominal muscle weakness. This can lead to atelectasis and pneumonia. And then lastly, if the condition can progress to frank respiratory failure, and this leads to progressively elevated arterial carbon dioxide levels, initially at night and leading to daytime hypoventilation. So I wanted to go over what happens during sleep so we can better understand the pathophysiology of sleep and breathing. So in normal individuals, this is what happens with sleep, right? So there is some reduction in the lung volume. There's also reduction in the muscle tone, and this is most pronounced in REM sleep due to the muscle atonia, which is physiologic. There is also reduction in the tidal volume, which depends on the diaphragm. And again, in REM sleep, this is going to be normally reduced. And then there is reduction in the chemosensitivity to hypercapnia and hypoxemia, which means that it takes a higher level of CO2 to stimulate ventilation and a lower level of oxygen also to stimulate ventilation. And then there is the natural reduction of upper airway pharyngodilator activity, leading to some degree of upper airway reduction, upper airway weakness. So when you add the neuromuscular component to sleep, there is the diaphragmatic weakness, there is that increased respiratory load and increased work of breathing. There is some derangement in the central respiratory drive for a certain disease. And also there is that anatomic and neurologic propensity to increase upper airway obstruction beyond what is physiologic. And then when you add the REM sleep component, so these patients really have an issue with breathing during sleep. So this is an example of a patient with REM sleep-related hypoventilation. So this is actually happens to be a home sleep study, which really just measures breathing events, sleep staging, and oxygen levels, as well as the AHI, as for sleep apnea. But you can appreciate here that, so this is the sleep staging at the bottom. The dark red bar signifies REM sleep. And the black graph right here is the oxygen saturation. And you can appreciate here that during non-REM sleep, the oxygen level is okay. But during REM sleep, the oxygen significantly reduces. So this is significant hypoxemia, which, in this case, we don't have CO2 monitoring. But if we added CO2 monitoring to the study, you'll probably see a corresponding rise in CO2 level during REM sleep. So you can see here, this is classic REM sleep hypoventilation. And this is not classic for obstructive sleep apnea. This is not the pattern we see in OSA. This is a pattern we see in patients with diaphragmatic weakness, whether it's neuromuscular disease or something else, but it's a diaphragmatic involvement. So putting it all together, right? So we have, this is what happens with respiratory involvement for, in general, neuromuscular disease as well as myasthenia. So we have the inspiratory muscle weakness. So this leads to ventilation problems, right? So which initially, as I mentioned repeatedly, is that you initially have sleep-related hypoventilation, and which can progress to daytime hypoventilation, meaning daytime respiratory failure. And then you have the expiratory muscle weakness. This leads to inability to protect the airway, cough dysfunction, and which leads to atelectasis and pneumonia and aspiration. And then the bulbar muscle weakness, which is commonly seen in myasthenia patients. This leads to upper airway dysfunction, and which leads to then sleep disorder breathing, which is really obstructive sleep apnea. So putting all this together, and you can see how they all interact and they all intertwine. So all three different muscle groups are contributing to respiratory involvement. So just one slide on the symptoms that these patients may get. So sleep symptoms are quite typical of sleep apnea. Patients can snore, patients can have witness apneas, gasping, choking from sleep, but they also can have orthopnea. They have a hard time, as soon as they go supine, they get short of breath. And frequent arousals is common. So patients may actually complain of insomnia instead of breathing issues, but the insomnia, it might be due to frequent arousals from the apneas. And then the daytime symptoms. So patients may have morning headache, they may have very nonspecific daytime fatigue, they may have frank daytime sleepiness. You may see that they have increase in nap duration or frequency of naps. So I always ask this about naps during the day to help me determine if there's an issue during sleep. They may notice reduced exercise capacity, and again, they may have just frank shortness of breath depending on the severity of symptoms. Okay, so let's move on to the respiratory evaluation and management. So I just put together a table here and all the potential different testing that we would do for a patient that I'm seeing in the clinic. So spirometry and respiratory muscle pressures, the maximal inspiratory pressure and the maximal expiratory pressure, as well as peak cough flow. To me, these are routine measurements that we do in the clinic. Now, if you don't have the ability to do in the clinic, then you have to send the patient to the pulmonary function lab. But hopefully this is something that is an option for you. So if the spirometry, sometimes the spirometry, it's difficult to know for sure if it's restrictive lung disease, which is neuromuscular disease, or obstructive. And if there's doubt, then you have to send the patient to the pulmonary function lab to get lung volume measurements. Also, if the FDC is normal and you suspect that there is weakness, you should do an upright a comparison between the upright and supine FDC. And I think when the difference is at least 15 to 20%, that's pretty clear that there is diaphragm involvement. Some studies will say 10%, but I think to be more conservative would be at least 15 to 20%. The rest of the tests are, to me, to consider depending on the patient's presentation. So a sleep study is always helpful, especially if the pulmonary function testing is normal, but you suspect that there is some nocturnal involvement. And with the sleep study, you can add CO2 surrogates, which is end-tidal or transcutaneous CO2. Now, home sleep testing classically is not recommended for neuromuscular disease. However, I think in the day and age of COVID-19, as well as just the advances in technology, I think it's reasonable to start with the home sleep testing because these patients do not want to come to the sleep lab. And especially if patient you just suspect sleep apnea and not diaphragmatic involvement, you could consider just a home sleep study. And I tend to do this a lot because, again, especially in the last year and a half because of COVID-19. Nocturnal oximetry is a poor, very crude way of looking at sleep respiratory parameters, very poor sensitivity and specificity, but I think it's a screening test. If you do the study and there is clear-cut hypoxemia, then you could go on to the home sleep testing or the in-lab polysomnogram. Getting arterial blood gas is never easy, but I recommend getting, it's easy to get a basic metabolic panel to look for the serum bicarb. However, keep in mind that if this is elevated, it means that the patient is, has pretty significant respiratory impairment because there's already evidence of daytime hypoventilation. And then radiology and echocardiography, depending on what you're suspecting with the patient. So one thing that I think the non-pulmonologists do not look at is what I call the flow volume loop. I encourage you to look at this because the photo itself really does help you determine what kind of process it is. So this is a typical restrictive process on the right. So normally you would have a nice, the patient inhales, you have a nice curve, and then the patient exhales, you have another nice curve. You can think of this as all this volume being squished to the left, to the wall, right? So this is restrictive. Patient can breathe in and out, so the volume is squished, right? So that's the typical pattern of restrictive physiology. On the other hand, obstructive, like COPD or asthma, this patient has normal inspiratory flow, but during expiration, there's this nice concavity. So just looking at this itself tells me what kind of process it is. So I encourage you to look at this if you have the opportunity in the pulmonary function report. So I get this a lot. How does a sleep study fit in? And I think that in the country, many people assume that a sleep study is necessary when it comes to neuromuscular disease. So I actually, although I'm a sleep specialist and I think a sleep study is a great tool, I really don't use a sleep study that often. I think the sleep study is beneficial because for patients who I just suspect obstructive sleep apnea, this is a great tool. Patients who I think may have isolated nocturnal hypoventilation, I think that's a great tool because you're not going to see that in the pulmonary function testing. And again, if for the rare patient who is on PAP therapy or non-invasive ventilation, and I feel that I cannot get the pressures adjusted appropriately, or there is patient ventilator asynchrony, then I would titrate the patient in the sleep lab, but that's rare. One thing I will say is, in the words of Bork and Gibson, daytime respiratory function has greater prognostic value than nocturnal measurements. And I think that is so true. You should never delay starting non-invasive ventilation while waiting for a diagnostic sleep study. So if your pulmonary function testing qualifies the patient for NIV, you should get started. Do not wait for a sleep study. On the other hand, if you really think it's just obstructive sleep apnea, then you have to do a study because you cannot get CPAP qualification without a sleep study. So moving on to non-invasive ventilation. So we all know this. The fundamental problem with neuromuscular respiratory impairment is that the patient has progressive ventilatory insufficiency leading to hypoventilation at night, progressing to daytime, and then frank respiratory failure. Oxygen alone is ineffective and can worsen hypoventilation by decreasing the hypoxic ventilatory drive. And I see this all the time, that patients coming in with oxygen that's prescribed by the primary care provider. So this is one of the few diseases, neuromuscular in general, where oxygen is actually toxic, and that we really try to provide education to patients that if anyone puts them on oxygen, they need to think twice and ask. Invasive ventilation, otherwise known as tracheostomy, comes with increased demands to both the patient and caregivers. And I think that this is kind of going away because NIV has become the treatment of choice and really the gold standard because of the advances in technology and availability and how effective it is. So I want to talk about NIV a little bit because I think this might be a topic that might be not as familiar to the non-pulmonologist. So I have this positive airway pressure, which is really the umbrella of NIV, right? So under positive airway pressure therapy, I have three categories. So you have CPAP and BiPAP or bi-level PAP. That category is really for the sleep apnea patients. And then I have the non-invasive ventilation category here, and this is in green. And then I'm going to go over this in detail a little more in the next few slides. And then there's another category called ASV, which stands for adaptive or auto servo ventilation. These devices are not meant for neuromuscular disease, and it's actually contraindicated because ASV devices can increase hypoventilation. So if you see anyone on ASV, you should really get them off the ASV device. Okay, so let's talk about NIV categories. So I break it down to three. These auto PAP devices, you know, these patients on auto CPAP, auto bi-level PAP, or auto BiPAP, these are really very simple devices. The next category are the respiratory assist devices. We call them as RADs. The DME companies love to use these coding, billing codes. These are the E470 and E471 devices. These are non-invasive only. They can provide advanced modes of ventilation in the S and ST. ST is spontaneous time or devices with a backup respiratory rate. And then you probably all have heard about or used this VAPS modality, which is volume assured pressure support, which is the most advanced modality for BiPAP devices. These devices are not portable, right? They don't have an internal battery and it requires electricity. The most advanced category of TAP devices in the home are the portable ventilators, and these are the different billing codes depending on if you're using it for invasive or non-invasive. The benefit of this is that, of course, it can do non-invasive with a mask interface and invasive with a tracheostomy. Comes in many more modalities than just these two modes, but it can do the backup rate and the VAPS as well. As you know, for those of you who also see the ALS, the Duchenne and the SMA and some ALS patients, this offers that mouthpiece ventilation mode, which is that sip and puff or sip ventilation for daytime use. And then the main benefit is that it has an internal battery and it is considered portable because it has that internal battery, so it doesn't require electricity. So when I look at these three categories, I superimpose the disorders that you would use this for. So for the simple auto-PAP devices, this is sleep-disorder breathing. This is that obstructive sleep apnea patients. And then for the respiratory assist devices, the more advanced devices, these are primarily used for patients with isolated sleep hypoventilation. And then the patients who actually have chronic respiratory failure, meaning daytime hypoventilation, these are the patients where I go for the portable ventilators. So not to really support any manufacturers or devices, but I just want to list the ones that are available in the United States so you know what's available. And if you do use these devices, you know that the Philips devices are on recall, and there has been a sort of a catastrophe across the country in the last few months because many patients are on the Philips devices. But anyway, in terms of the respiratory assist devices, these are the options, only two out there, which is the Philips, known as the DreamStation BiPAP, and the other manufacturer is ResMed, and this is known as the AirCurve VPAP or bilevel PAP. And these are the options for modalities, and you know that a lot of patients are on the AVAPs or the IVAPs modalities. For the ventilators, there's many more than this, but these are the 5, I would say, commonly used ventilators with pretty up-to-date technology. So the Philips Trilogy is actually being phased out, and it's no longer being made, but it's on recall anyway. The new device by Philips is called the Evo. And then the ResMed Astral is also another home ventilator. And the latest ones in the market that just came to United States are going to be the Breas, Vivo, and then the Ventec Voxen. Now, this is a particular multi-function ventilator. It has the feature of ventilation, oxygen, cough assist, suction, oral suction, and nebulizer all in one ventilator. So it's a quite sophisticated ventilator to use. Okay, so let's talk about how do we get coverage for these devices. And I think this is something that is difficult to grasp, for many people. So let's talk about the coverage for the respiratory assist device, right? Your devices with a backup modality like the BiPAP, AVAP, so the ResMed, STA, IVAP devices. So these are the 3 criteria. Under restrictive thoracic disorders, there has to be documentation of neuromuscular disease or thoracic cage abnormality like kyphoscoliosis. Under category B, you have to have one of these 4. So your arterial blood gas while awake needs to be at least 45 or higher. You can have an oximeter, overnight oximeter, or daytime, it doesn't matter. There has to be a 2-hour recording showing that the SpO2 is below or at 88% for at least 5 continuous minutes. Now, these 2 are a little hard to get. The easiest way to get this, right, is, as we all know, is using the pulmonary function test. And this is particular for neuromuscular disease, right? So you have to either have an FVC of 50% predicted or lower, or the maximal inspiratory pressure, the MIP, has to be less than -60. So -50, -40, and so forth, right? So that's the second criteria. The third criteria is a documentation criteria. In your notes, you need to say that COPD, and actually they forgot here, it's also OSA, does not contribute significantly to the patient's pulmonary limitation. That has to be on your clinical note when you order these devices. You have to meet all three criteria, A, B, and C, and then you can get your BiPAP or the BiPAP with the backup rate, which is the ST or the AVAPS modality. So I tell my fellows, this is how I remember it, the 45, 50, 60 rule, right? 45 for arterial blood gas, 50 for your SDC, and 60 for your MIP. Need one of those. Note that the sleep study is not part of this coverage criteria. What about the ventilator? So the ventilator, this is the Medicare definition. I mean, this is taken directly from the Medicare website. So for neuromuscular diseases and a few others, but the choice of an appropriate treatment plan, including the determination to use a ventilator or a bilevel tap device, is made based upon the specifics of each individual beneficiary's medical condition. So this is a documentation by the provider. You actually don't need to use the RADS criteria to get a ventilator. However, I think in majority of most parts of the United States, these durable medical equipment companies, the DME companies, tend to use the RADS criteria and apply it to the ventilator. But technically, you can actually just find your notes that a ventilator is needed, and you don't have to go through by one of those criteria. Okay, so how do I qualify for NIV, right? So for the RADS, this is a summary for you if you wanted to review it later, right? You need that neuromuscular diagnosis, you need to know one of these criteria for the PFTs, document that COPD or OSA does not contribute to the patient's pulmonary limitation. The last thing here is that if you're going to use a RAD, there's this criteria that I think unless you're a sleep specialist, majority of providers may not realize this, is that there's this 90-day compliance check, which means that at 90 days after, there has to be a face-to-face follow-up with the physician or the provider saying that the patient's benefiting and using the device. And the DME companies themselves will download a compliance check. And that means that out of those 90 days, there has to be 30 consecutive nights where the patient's using it at least for 4 hours per night without a break. So if the patient doesn't meet those two criteria, then the device is no longer covered and the patient has to return the device. The ventilator, on the other hand, is a little different, right? So again, as I said, the physician's documentation is key to getting the ventilator. Detailed assessment of symptoms, right? So I would put in my note that the ventilator is superior to the RAD because the patient's PFT is impaired. FVC is 20% predicted, for example. Severe daytime symptoms, this patient needs daytime NIV use. The patient has a wheelchair, or the patient is so severe that a life-threatening event would potentially, cause death or harm. So that's how I would qualify for a ventilator. And then I also get asked the question, well, which device do I use, right, for my patient? So I think the easy answer is that device that you want to choose depends on the severity of disease. So just to break it down, to simplify it, I think an early stage, when your FVC is relatively preserved and you have mainly isolated sleep disorder breathing, you can start with the RADS device. And you start low. I actually start very low pressures because I want the patient to acclimate, and then I increase the pressures with time. So if you're seeing a patient with rapidly progressive or already has chronic respiratory failure, then I go straight for a ventilator, and I may initiate daytime use if necessary. So I want to go over a little bit about the different modalities. So ST is basically spontaneous time, and it's a backup rate modality. Now, one thing to remember that this is sort of a reassurance. It falsely reassures the provider because the fixed bilevel will only deliver a breath if the patient does not breathe after a certain amount of time. So it doesn't number one is that it doesn't guarantee a consistent tidal volume, right? Because the volume is the variable here because it's a fixed pressure. So for example, it's delivering an IPAP of 10 and an EPAP of 5 no matter what. So the volume may vary with each breath. The other thing is that the backup rate that you set, let's say you set the backup rate at 12. Well, unless the patient's own breath goes below 12, the backup rate doesn't kick in. So in some way, it's a little bit of a false reassurance if the patient is breathing above the backup rate, okay? Versus the volume assured pressure support mode. This is the most advanced bi-level PAP mode. It's an accessory mode to bi-level PAP, right? And basically the algorithm is that it guarantees a tidal volume per breath. So for example, if a patient's tidal volume is here in yellow, and then the target tidal volume is the dotted yellow line here. So you can appreciate here that the first breath is below the target volume. So the device is going to kick up the IPAP pressure. So IPAP min is here, IPAP max up here. So this is that range, this is that delta, and it's going to change breath by breath to get that patient the volume that you dialed in on the machine, right? So they kick up the IPAP to up here, and now the patient's volume is over the target volume. Now it's going to back down a little bit to meet that target. So it's going to do this, and it does this pretty well unless there's a high leak in the first few hours of the night, and after that it just stays status quo. So it's a pretty neat, highly adaptive modality. And now there's no, I would say that there's no head-to-head comparison looking at ST versus AVAPS or VAPS modality, but I think that theoretically, it does provide a more consistent tidal volume than the ST mode. So I'm not going to go over this, but just so if you wanted to just kind of use this as a review, I sort of set the starting pressures of a patient who's naive to BiPAP, and then also what you want to target as a patient is acclimating to the device and getting used to using it. And then if you're using the VAS modality, I sort of also put down the different settings that you can consider. And this is not for. I sort of added both the Philips device and the ResMed device because it's hard to know, which one you'd be using. So, all right. So one thought about CPAP. CPAP is like my pet peeve because it really is meant for OSA only when the respiratory parameters are preserved or relatively normal. It should not be used when PFTs are abnormal. And it can actually increase work of breathing, right? Because the patient's breathing out against this constant pressure, which cannot be good, and it can increase work of breathing during sleep. Just remember that bi-level and more advanced modes of NIV, which treat both OSA and ventilatory impairment. So this is why, I think it's, if you can, try to get the NIV devices. One thing, though, is if you're going to use these devices, it is important to also learn how to monitor remote monitoring, especially in COVID-19 times, right? These devices are quite neat. They capture use adherence. They have this pneumotachograph, and it really measures all kinds of respiratory parameters. You can add oximetry. You can add integrated CO2 monitoring. So it's really neat, and it transfers all this to this cloud-based platform, and you can log into that platform and look at your patient's use and what they're doing. So I do this for all of my patients when they see me, and I make adjustments depending on the disease progression and stage and so forth. So here's just some examples of what it looks like, right? So I can see exactly what the settings are, what the patient's doing, the therapy itself, the details of therapy, pressures, leak, tidal volume, respiratory rate, and so forth. So it's actually pretty neat. I think we forget about mask a lot, and I think that I will say that NIV is only as effective as the mask fit. So the mask doesn't fit, NIV is not effective. This is a recent clinical practice guideline that's put forth a year ago by the American Thoracic Society. And they did a huge literature search in looking at all the different mask options and what the side effects and the benefits are. So it comes down to really this. These are your mask options available, right? These are different styles of masks. And then the mouth leak is always an issue, right? So these are potential causes of mouth leak. And you can see here that with a nasal mask, there's a lot of advantages here, right? It's obviously more comfortable, lower leak, higher adherence, less risk of aspiration, lower risk of aerophagia, which is always a big problem for a lot of our patients. And look at this compared to the oral nasal mask. There's like two advantages, and there's a lot of disadvantages here. I think we tend to say, like, if someone has a mouth leak, we go straight for an oral nasal, or otherwise known as a full face mask. But I think that's the wrong move. I think you should, even if they are mouth breathers, still use a nasal mask first and foremost, because the key here is using it and adherence and feeling comfortable with using it. And then you can always make that change if you need to. But if they're not going to be able to use it, then there's no point, right? NIV is not going to be effective. So I always go for the nasal mask first, nasal or pillows, and then I go to the oral nasal if only if necessary. And here's that rationale behind this, right? So here's your nasal mask, right? So air is coming in, and you can see here that all the plus signs are air coming in. So the nasal mask splints the upper airway open, right? So here's your upper airway, and it pushes that soft palate, which is the orange, against the tongue. So pressurized air nicely flows down the windpipe or the airway. Here is your oral nasal mask, the full face mask. It actually neutralizes the splinting effect of tap therapy. So all this air is going in, and now it's sort of the soft palate is not really pushed against the tongue, and now you've lost that nice upper airway pathway, right? So that's why the oral nasal mask is not so effective. We think it is, but that's actually not. So these are the mask options, right? The pillows always have these little cones that go into the nostrils. This is a nasal mask. Even though it doesn't look like nasal, it's nasal because you're just cupping the nose. And then this is your oral nasal, the full face mask. By definition, it covers the nose and the mouth. Okay, so one slide about airway clearance. Now, one thing I will say is CMS does not cover mechanical airway clearance for MG. So it's not easy to get this in the outpatient setting, but we use it in the inpatient setting. So airway clearance, also lung volume recruitment, right? So there's 3 ways to do this. You can use a self-inflating bag like the ambu bag with a one-way valve and just do breath stacking. So if you can't get the mechanical cough assist, you can do this. You can use, if the patient has a ventilator, you can use a volume cycle mode and do breath stacking. And then the easiest way is obviously the mechanical exflator, which is the cough assist. But again, like I said, CMS doesn't cover cough assist for MG. Initial airway clearance, when do you do this? So when the peak cough flow is less than 270 liters per minute, I usually initiate airway clearance, either manually, can't get this for CMS patients, or when the FVC is less than 40% predicted. Keep in mind that when the peak cough flow is less than 160, this is pretty dangerous. These patients are at high risk for acute respiratory failure, high risk for tracheostomy because they cannot protect their airway at this point. Okay, so switching gears completely, I'm going to discuss the myasthenic crisis and management in the ICU. And I realize that it depends on where you practice. I think sometimes, the intensivist or the pulmonologist will completely, control this management. But I think for a lot of neurologists, they are still the experts. And if you practice in an area where, your pulmonologist is not going to know any of this either, which is actually quite common. So I think that it helps for the neurologist to provide expertise to the pulmonologist in this case. So definition, I think you know this, but I think we loosely use definition of crisis as an exacerbation that requires intubation or even non-invasive ventilation, or someone that has a crisis that's putting them at risk for acute respiratory failure. So common triggers, as you all know, could be a lot, right? Infection, electrolyte abnormalities, thyroid, surgery, pregnancy, medication change. Non-adherence is a common problem. And then tapering of immunosuppressants, and they can also get adrenal crisis if they're on prednisone or steroids. I always want to make sure that you remember you want to look for non-MG causes. Just because they're short of breath does not mean they have an MG crisis. It could be completely separate. It could be pneumonia, heart failure, PE, something completely unrelated to MG. One thing I want to say is that acute MG crisis is also associated with severe bulbar dysfunction, right? So unlike another neuromuscular process like ALS or something else, these patients are at severe high aspiration risk. So in this particular case, it is appropriate to provide early endotracheal intubation because unlike other neuromuscular diseases, there's effective therapy options, right? So intubation is okay because it is a bridge to effective weaning. The diagnostic evaluation, you want to make sure, like I said, please try to exclude other active issues. And you should have an X-ray of the chest, an EKG, CT chest, etc. The FVC should be reduced if it's a crisis. If the FVC is normal, then the shortness of breath is probably from something else. I do not depend on ABG, arterial gas. Hypercapnia is usually a very late finding. I will obtain it if the patient has chronic hypercapnia, so someone that has hypercapnic COPD or obesity, hypoventilation, or if they have altered mental status, then I will get the ABG. But otherwise, I don't think it helps you. And basing intubation on ABG alone is probably not the right thing to do. And I know in this case that it's the pulmonologist or the intensivist is going to be making this decision. But I think that there are many other factors to base intubation on, especially looking at the patient and seeing what's happening to the patient and not just the ABG alone. Okay, so monitor respiratory parameters, right? So this is the vital capacity, right? So normal is usually going to be 60 cc's per kilo, and depending on the patient's size, but it's going to be, for a small patient, 3.5 liters, for bigger patients, 5 liters. So it's concerning when the vital capacity is less than 30 cc's per kilo. And when it's less than 15 to 20, this patient likely is going to be intubated. So these are just numbers to remember and watch out for. I think I can't stress enough the bulbar dysfunction. This is so important to monitor because this is what's going to get the patient to decompensate quickly. And I also think it's important to trend FVC. However, at least in my ICU, they do it way too often, like every 2 to 4 hours. I think it's the patient's just going to tire out, and also they do it during sleep. And I think it's important for these patients to rest. So I recommend doing this maybe 2 to 3 times daily, but only during awake and let the patient sleep. There's no reason to have the RT come to the bedside at 3 in the morning to do this FVC. Just one slide of medications, and I think you probably know this more than I do, but some medications to avoid because it can worsen the condition. And then respiratory support, right? So there's 2 options. There's non-invasive and invasive. So non-invasive, obviously, we try to implement NIV as a first-line therapy as soon as possible. We don't wait till the patient's really short of breath. And it should be in the ICU setting for close monitoring. Now, I will say that you can do NIV is bilevel PAP therapy, but you can also consider high-flow nasal cannula. This is becoming more and more common and more popular. High-flow nasal cannula is not oxygen-led nasal cannula. It's very high flow, like 40 to 60 liters of just air, and then you bleed in oxygen if you need to. But it's more comfortable than the mask interface for BiPAP for some patients, and it can reduce desk-paced ventilation and improve ventilation. So you can use this if the patient really cannot do BiPAP, has a hard time with the mask interface, then do high flow. And the key thing here is to start early, right? You want to capture that moment when the work of breathing is increasing and reduce it right away, and you want to prevent that respiratory exhaustion, because once you pass that point of respiratory exhaustion, the patient's getting intubated. So intubation depends on the patient's appearance, that bedside evaluation. I look at the patient, the work of breathing, using all accessory muscles. I look at the cough strength. Obviously, if the patient cannot protect the airway, that's concerning. Of course, I look at the FVC trending, and it's trending lower and lower, and the values are getting very alarming. And then, of course, worsening hypercapnia. Keep in mind, like, I don't recommend doing ABGs all the time, but if you have an ABG for someone who is chronically hypercapnic and then the patient's worse, then that's a worrying, concerning sign as well. And then there's other conditions, right? The patient might have aspirated, has an infection now, and there's significant hypoxemia. That might be, conditions where you have to intubate the patient. I get asked this a lot, is what factors are considered high risk for needing long-term invasive ventilation. So based on the literature, these are some of the risk factors: and older age, having prolonged atelectasis, ventilator-associated pneumonia is a big problem. And then I think you know this already, that the muscle-specific receptor tyrosine kinase antibody, it's rare, but it can lead to long-term invasive mechanical ventilation. And this is seen in younger women with significant bulbar symptoms and diaphragm weakness. So this is one study that I found over 10 years ago, looking at the role of NIV and the factors that predict extubation outcomes in the crisis. So this is a retrospective review looking at 41 episodes of crisis, and they were in two categories, NIV or immediate intubation. And out of the 14 patients, 8 had NIV success, and the failure went over to the invasive mechanical ventilation. So you can see here that it looks at factors that predict NIV success and factors predicting extubation outcome. So the bicarb here, serum bicarb, predicts NIV failure versus success. And you can see here that those who had an elevated bicarb or chronic CO2 elevation are the group that more likely will have NIV failure. So also looking at the predictors of extubation success, right? So they determined that the maximal expiratory pressure, which is a measurement of your cough strength and the ability to clear airway, clear respiratory secretions from the airway, is another predictor of extubation success. And you can see here that it's the only one that was significant. Also, duration of mechanical ventilation, and then the longer the patient is intubated, the longer in the ICU, the more likely the patient will have an extubation failure, right? And causes of extubation failure, as I mentioned, is based on the study, the cough strength, and the ability to protect the airway, the ability to clear respiratory secretions is very important, right? So poor cough, increased mucus plug, sputum production, hypocapnia, hypoxemia, these are all signs of extubation failure. And for this particular study, what they found was that prior to tracheostomy, these patients were ventilated for quite a number of days, 26 days, so quite long here, almost close to 4 weeks before having a tracheostomy. So criteria for extubation, right? So pretty, it makes common sense here that, you want to see improved pulmonary function testing. Unlike other neuromuscular disease, I don't recommend for example, ALS patients, I do not recommend these extubation trials, looking at the spontaneous breathing trial and monitoring this rapid shallow breathing index. These are all weaning parameters. I don't recommend doing this for the other neuromuscular patients, but for myasthenia patients, it's important to do this because a number of these patients can get better and can go back to their baseline, which is someone who isn't on NIV to begin with. They obviously need to be awake and mentally appropriate. They have to be hemodynamically stable. Usually their FiO2 requirement should be less than 0.4, and their SpO2 correspondingly should be at least 94% or higher. And it's very important here that they can manage their own airway secretion. So in summary, respiratory impairment in myasthenia gravis ranges from obstructive sleep apnea to chronic respiratory failure. A sleep study is indicated when sleep apnea is suspected in the setting of normal pulmonary function testing. A sleep study is not a requirement for NIV initiation if the patient meets criteria by the PFT testing. It is important to monitor use of NIV and adjust settings to match the patient's respiratory status. For the crisis, you want to monitor bulbar function, use of accessory respiratory muscles, and trend FVC to prepare for impending respiratory failure. Early NIV initiation prevents intubation and shortens the hospital length of stay. Unlike other neuromuscular diseases, intubation is accepted as there is effective treatment which allows for successful weaning from invasive mechanical ventilation. Airway clearance is essential in extubation success, and extubation failure is associated with prolonged duration of mechanical ventilation and ventilator-associated pneumonia. I also wanted to have just a few slides on COVID-19. I think in general, COVID-19, the guidelines follow the CDC guidelines, right? So vaccination, I have many patients ask me about this, and I think I actually say we should do what CDC guidelines say. These patients should be vaccinated. And the booster, again, is recommended per CDC guidelines, which is, right, as of now, the booster is recommended for people who are 65 or older, those with the immunocompromised status, right, healthcare workers, especially frontline workers. Here is the tricky part. Medical conditions that puts patient at high risk for severe COVID-19 infection, which means they get hospitalized for COVID-19. So I don't think myasthenia patients are exactly in the immunocompromised state. Maybe if they're on chronic steroids, but I do think that there are, depending on the patient's respiratory status, if they have compromised respiratory status, meaning their FVC is significantly low. So an FVC of 60% or maybe 50% or lower might be of a concern. And clearly, if they're already on NIV, or obviously if they're on invasive ventilation, especially if they're on it full time versus just sleep only, they might be at higher risk for having severe COVID-19 infection. What about exposure and infection? So I think that I really try to get, if I know that one of my patients is clearly exposed to a COVID patient or is infected and they're not hospitalized, I think this monoclonal antibody called REGEN-COV is a very good option, right? This is for non-hospitalized patients so the criteria is that they have to have high risk for developing severe COVID-19 infection. So again, it can be used for post-exposure prophylaxis. So my MG patient with an FVC of 40% on NIV gets exposed to someone with COVID-19 for sure, then I would consider this. Also, they have confirmed mild to moderate infection. They're at home, they have some symptoms, they don't need to be hospitalized. This is a good option for them because it can prevent hospitalization and severe COVID-19. I would recommend to continue NIV therapy. Do not stop. And I think in the early days of COVID, there was a lot of talk about what to do with NIV because it is considered a high aerosol generating procedure or treatment. But I think we've learned a lot nowadays, a year and a half later. So I think continuing NIV is appropriate. And I think these patients, if they are infected, they just need to isolate themselves. There was a lot of talk about, converting the NIV unit to this closed circuit system to prevent infection and so forth. So it is theoretically possible if you have a patient on NIV at home and you have the ability to use a high quality viral filter, have the CO2 exhalation port, have this non-vented oral nasal mask, right? It is very difficult to do in the outpatient setting because this particular protocol and putting all this together, it's very high level expertise by your DME provider. So you're going to have to use a DME company, or the DME company that you are using has to be a company that has, a lot of expertise in ventilator management. Your provider needs to be comfortable with this. The caregiver needs to be comfortable with this. So it's not easy to do. Non-vented masks are not available in the outpatient setting. These are only in the hospital. So it's just not something, theoretically it makes sense, but it's not something that most people can do. So the other thing is that the closed circuit system that, theoretically, again, prevents the viral dispersion, it's really not a closed system, right? Because unless you are intubated and you're on a ventilator and it's a completely closed system, realistically, NIV is still an open circuit system. No matter how you want to, change the circuit, it is still an open circuit system because you can never prevent that mass leak completely. So here are some examples of, what you can potentially do, right? So this is an Astral ventilator. You notice that these are viral filters. One circuit is going to the patient. This is a non-vented full face mask. Non-vented means that there's no CO2 port. So you can imagine the patient gets the breath, right, from the ventilator. Non-vented mask. There's a CO2 port here. Patient's breathing out viral particles. Here is the viral filter. Here's a CO2 port. So CO2 gets exhaled. Patient's not rebreathing CO2. Viral particles get captured in the viral filter, and that exhalation air goes back to the ventilator, right, with the filter again. So I think that theoretically, it's possible, but many companies are not going to have familiarity doing this, and not going to be comfortable doing this in the home setting. And here's another system. This is the Evo, the Philips Evo, and then this is one of the older BiPAP devices using a single circuit limb, again, with a viral filter and a CO2 port. So like I said, a year and a half ago, we were all trying to do this, but I think it is not easy to do. I will say, though, that if they're on NIV or CPAP at home, I think it's important to clean out, do pretty intensive cleaning of the equipment. And this is a nice article that you can download for your patient. It is for home patients on PAP therapy that was published by the American, it's 2021, just a few months ago by the American Thoracic Society. So it is a resource for patients to read. And I think that's all I have.
Thank you, Dr. Cal. That was
Let me stop sharing.
Can you hear me?
Happy to take questions.
Dr. Cal, can you hear me?
I can hear you.
Okay, well, first of all, thank you. That was a most informative lecture and very thorough. We do have some questions, and I'll post the first one.
Sure.
Let me see. There we go. Can you see that?
Yes, I can see that. How do you balance EPAP settings in NIV for diaphragm weakness and still control sleep apnea when higher EPAP is needed? So I will say that when a patient has diaphragmatic weakness or significant diaphragmatic weakness, I think that I would say that the upper airway closure sort of goes in the back burner. It is important to ventilate the patient, right? So in order to ventilate the patient with NIV, you have to keep that upper airway open. So you have to have some degree of EPAP. Usually 4 to 6 is adequate. I don't usually go higher than 6. And then I use the high pressure support to ventilate the patient, right? Because the EPAP just takes away obstructive apneas. The hypopneas can be taken away. Hypopneas is basically upper airway closure or upper airway reduction. The airflow is reduced, but the upper airway is not collapsed, which is an obstructive apnea. So you don't need a lot to open the upper airway with EPAP. You just need 4 to 6 in general, but you can use the pressure support to take away any airflow reduction in the upper airway. Now, that being said, if you have a morbidly obese patient with MG, right, with diaphragmatic weakness, then you're going to have to use a higher EPAP. There are some devices with an auto-titrating EPAP. For example, the EVO. So the old Philips trilogy has this AVAPS AE mode. However, the EVO also has the AVAPS AE, and so does the Astral ventilator. So you could actually program an auto-titrating EPAP range, for example, 4 to 7, 4 to 8, and let the machine decide if there is upper airway obstruction, then the EPAP can ramp up. And when you look at the download, then you can see how much EPAP is needed, and then you can dial the EPAP in and tighten your range.
Thank you.
So I hope that explains it.
We have another question.
When are post-oximetry readings helpful, not helpful in MG patients? So I think in general, post-oximetry readings are not that helpful because there's a lot of artifacts. And it's not just MG patients, but it's for every patient. If you don't have access to, for example, so it's hard to have access to the sleep lab, and it's even hard to get access to home sleep testing units, right? What I use for MG, how I use post-oximetry is I will, if someone is already on a PAP device or a ventilator, I want to make sure that there is that the ventilator is working well and ventilation, oxygenation is adequate, then I will order that post-oximetry, nocturnal post-oximetry recording throughout the entire night with the patient on that device, right? And then I will look at it. And so although I don't have CO2 monitoring, if the post-oximetry reading is always above 90%, I'm going to assume that there probably isn't much hypoventilation going on there. But the graph itself helps you. So when you look at the post-oximetry reading, it gives you a summary, like for example, 10 p.m. to 6 a.m. And if you see trends where, the reading looks like it looks great, stable at 90%, like what I showed you in my slide, and then it drops dramatically, and then it goes back up, and it recovers for a while, and then it goes back down again, you can pretty much know that that's REM sleep, because REM sleep happens in spurts, right? Every 90 to 120 minutes, about 3 or 4 times during the night. So if you see that, that's a very characteristic, a very typical pattern that the patient's ventilation, oxygenation still needs to be improved during sleep. That's how I use the oximetry readings.
The next question I'm going to sort of add to it, the question is, please briefly review if treatment varies for MG patients with COPD. I would like to tag on to that question if you could briefly talk about not just only the COVID vaccines, but recommended vaccinations in general for our patients for overall health. We get a lot of questions about pneumonia, strep pneumonia, flu, and so just to talk about that to our primary care physicians as well, if you don't mind.
Yeah. So the first question is the COPD patient. So COPD is, there's so many phenotypes. There's a COPD patient who just has COPD but has no ventilatory issues at night. There's a COPD patient who needs oxygen at night only. There's the phenotype that needs oxygen 24 hours a day. And then there's a COPD patient that's hypercapnic that needs NIV. So you kind of have to know which phenotype you're dealing with. But in general, if you have a patient with COPD who requires oxygen, whether it's night or day, and they have MG, I would add NIV to that patient, and I would keep the oxygen on, right? Because as long as the patient is on NIV, I'm not going to be worried about hypercapnia. So the patient would use oxygen during the day, and then at night the patient would connect the oxygen, bleed it into the NIV device, whether it's a RAD device or a CPAP device even, or a ventilator, and I would use it that way. And then you can be reassured that ventilation is going to be controlled as well as oxygenation. If the patients are already on NIV for hypercapnic COPD, then it sort of makes it a little easier, except that it depends on how severe the MG is. If the MG is really severe, and let's say FVC is, like 30% predicted, then I may have to control ventilation a little more. Remember, because a COPD patient doesn't have diaphragmatic weakness, can still trigger the ventilator, can still get that breath easily. But a patient with diaphragmatic weakness might try to trigger, but cannot get the breath because the diaphragm is too weak. So in that case, I will have to tweak the ventilator setting so that the trigger sensitivity is much more sensitive, so that minimal trigger will initiate the breath. These are technicalities of the ventilator or the modalities that I would use. And I'm happy to go into detail if you can email me or something later. But that's how I would manage a COPD patient with MG. In terms of vaccination, so I think MG doesn't change how the recommendations for vaccine for the influenza. I mean, that should be done every year, right? Just like I think for majority of patients, and especially if they have respiratory weakness, it is really important that they don't get influenza pneumonia, because influenza pneumonia can be pretty severe and can put patients in the ICU and they get intubated, and if they're older age, there's a high mortality. So I think it's important to get the influenza vaccine every year. In terms of the pneumonia vaccine, there's the Prevnar 13, and then there's that 23 valent. There is a CDC guideline for that, and I think majority of PCPs do follow that pretty well, and I think it should be followed for MG patients. I don't see a reason why that should not be followed. Usually the 13, Prevnar 13 is given after 65, and hopefully the patient will already have the 23 valent before 65.
Thank you for that. Excellent.
I don't know if that helps, but there's a very clear-cut CDC guideline on those two vaccines, and I think it's highly recommended. You shouldn't skip it if you have MG.
Well, thank you for just reminding us as healthcare professionals not to forget that discussion and that need. So we're going to conclude.
Oh, I will say though those vaccines, if you don't do it with PCP, sometimes your insurance charges you, right? Because those vaccines it's covered under insurance. Like even for me as a pulmonologist, I try to have the PCPs do that, because if I do it in my clinic, a lot of insurance will charge you. So just remember that. So I think it's important to remind the PCP to get it done, and not have, neurology clinics are not going to have this, but just a reminder.
So I think we have another question, but it's really if you could provide the citation that you gave at the end, the most recent citation about COVID and NIV. If you could provide that on your slide again for our attendees, that would be excellent. Or,
Sure.
can we turn off the poll V so that, and pull back up Dr. Cowell's slides, please? Thank you. Dr. Cowell?
Sure. Let me share my screen here. I don't know that patients can access this. I think the providers will have to access it and then print it out for patients. It's 2021 and then 12, volume 12.
Is it on PubMed?
It is on PubMed.
Okay.
Yeah, it is on PubMed for sure. Sorry, 2021. I left out the two.
Okay. Well, I wanted
And I can also send it to you if you want, and then you can just provide it to the attendees.
Why don't we do that?
Okay.
That would be great. And so thank you, Dr. Cowell, for an excellent discussion. I just wanted to remind our attendees, both healthcare professionals and patients, of course, who have connected with us, we are, again, giving the patient-oriented conference tomorrow. We'll be covering similar concepts for patients and their families, but many healthcare professionals connect as well. Dr. Cowell will also join us at the end for a short panel discussion about COVID, vaccinations, the infection management, many things that our patients have questions about, and maybe you as a healthcare professional might use that opportunity again. Dr. Cowell, thank you so much. I look forward to working with you tomorrow as well, and we will conclude. If someone can bring up my concluding slides, I would appreciate it. Thank you, Dr. Cowell. So we've gone over a little bit, hopefully not too much, and I hope that you've enjoyed this conference. It's so very important that you give us feedback about the content. We try to be respectful of your time, given that we're virtual. I'm going to step off so that I can make sure to get my notes together. And so again, please give us feedback. We'll be looking at that, looking at ways to improve. I want to take this opportunity to recognize our sponsors. Alexion, Arginex, Horizon Therapeutics, Janssen and UCB, as well as our continuing medical education staff and coordination, Ms. Juanita Young and Chris Rawls, our speakers, Dr. Cowell, Dr. Anderson, Dr. Schroff, and the Myasthenia Gravis Foundation of America has been really our support, provided infrastructure, direction all along the way, and I want to recognize them for their leadership in America and beyond in terms of research, education, and resources and innovation, and particularly call out Dove 11, and of course Nancy Law, who is the Chief Executive. I'd like to recognize Dalia Angel and Enrique Sirius, who is our own neurology IT support as well. Before we end, I wanted to also bring you up to date with the calendar or the agenda for tomorrow's session. We begin at the same time, and we hopefully will end at the same time. So with that, thank you for joining us. We look forward to doing this again next year. Take care.